Good morning, and I would like to welcome everyone who is present in the chamber and all those who are listening online to the business of the Health Scrutiny Committee for Lincolnshire. I would like to add that for those of us in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception and assemble in the car park at the front of the building and await further instructions. I would also request all members to place their phones on silent and to try and ensure everyone has the opportunity to ask a question, to ask a maximum of 2 questions per item and to keep these succinct and concise. However, I will close down the debate to ensure we keep to time if needed and would ask you indicate early to guarantee your question. As the meeting is being streamed in the usual way, I would like to remind you that all your comments will remain accessible online as the meeting recording remains on the council's website. I'd now like to move into agenda item 1, apologies for absence and replacement members. Trina.
Thank you, Chairman. We've received apologies for absence from Councillor Jeanette McGee and Councillor Susanna Welbury. We've also had an apology from Councillor Sue Woolley, Executive Councillor, NHS Liaison, Integrated Care System, Registration and Coroners. Thank you.
Thank you, Trina. I'll now move on to agenda item 2, declarations of members' interest. Does anyone have any interest to declare at this point? Councillor Kendrick, please.
Thank you, Chairman. My usual declaration, I'm a stakeholder governor of LPFT. Thank you.
Thank you. If any arise as we go along, then please raise your hand. Councillor Matthews. Sorry, Councillor Matthews, would you mind just putting on your microphone?
Apologise. I am also a partner governor of LPFT, a county council representative.
Okay, thank you. That's noted. Yeah, Councillor Smith.
Thank you, Chairman. Just for clarification for the members of the public, it is on my RTPI, but I am a member of the Veterans Advisory and Pension Committee, and I'm declaring that in respect to item 6, which is the Joint Health and Wellbeing Strategy.
Okay, thank you. And Councillor Morgan.
Just to let you know, I am on the patient panel of ULHT.
Thank you. They're all down. I'll now move on to agenda item 3, the minutes. To confirm the minutes of the meeting held on the 24th of January 2024 as a correct record. They are found on pages 3 to 14 of the agenda pack, and as the committee has had the opportunity to read these in advance, I plan on taking these on block. Do I have a proposer for those, please? Thank you, Councillor Smith, and seconded Councillor Hakes. All those in favour, please show. Thank you. That's supported. Any against? And any abstentions? No, that's lovely, thank you. We'll now move on to agenda item 4, the Chairman's announcements. My announcements were circulated as part of the agenda and supplementary announcements were circulated on the 20th of February. Do I have any questions on my announcements? Councillor Smith, please.
Thank you, Chairman, and with your indulgence I do have 3 points, but I shall try and be brief with them. I note with concern the comments around Vallas Ward. This backs up the comments I've made previously on this issue, Chairman, with regards to the reduction in beds with respect to psychiatric and psychotic care within Lincolnshire. And I would ask that have LPFT reassess the estate and their recent decisions on closure of high-intensity beds, and if they haven't, why? Because this seems to bear fruit to the comments that I and others have made previously on this. Secondly, Chairman, which relates to the first point with regards to psychiatric in the intensive care unit, do we know what's caused the Legionella outbreak in the building? And are LPFT confident that they can get the bacteria removed from the building and ensure that a similar situation does not occur in the future, so the building can be open as quickly as possible? And lastly, Chairman, what is being proposed with regards to the NHS dental recovery plan is, in my mind, simply tinkering around the edges, when the only real way to solve this problem, Chairman, is to actually change the dentistry contract from 2006, as we've discussed previously when this has been here. That is when dentistry had a mass exodus of NHS dentists because, quite simply, Chairman, they weren't being paid for what they were actually doing, and it's still a problem now. I look forward to our report that we're having on this in June, because I think we need to have a serious look at this, Chairman, because I don't think while the reforms are welcome, I don't think they will solve it. And I include those reforms, when I say reforms that were in your supplementary announcements, I do find them quite concerning, that actually what they're doing is, we're that short on dentistry, we're going to stop you having to go through your years of examinations, and we're going to have you supervise whilst you undertake work. That really does concern me, because they have been there for a reason, Chairman. They're there for safety, and now they're saying because we can't recruit or get people who were NHS dentists back into the system, we're going to circumvent that. And that, to me, is deeply concerning, and I think we need to watch that closely, Chairman. Thank you for your indulgence.
Thank you, Councillor Smith. And as you say, we've got the report coming in June, so we can sort of hold our questions till then. I will bring in Simon in terms of the Legionella side of things and the psychiatric side, and just see if he can help out.
Yes, thank you, Chairman. I think maybe it might be pertinent to ask LPFT to come along if they're free, because there's a couple of issues, not just the Legionella, but the issue with the high dependency mental health unit. So it could be that these developments might merit an item on. That's my suggestion to the committee. Thank you, Chairman.
Yeah, thank you. And we'll pick that up on the work programme. So, Councillor Morgan, please.
Thank you. It was just an update. I've done a bit more research into the issue raised regarding patient transport, and I've had feedback via ULHT that actually the parameters regarding patient transport are set at national level. It's under NHS England, so any changes in policy would actually have to go that high up the ladder. However, there are some strict criteria around when transport can be offered, including safeguarding, and I think it's worth us looking, because we were going to put this on our work plan, I think it's worth us looking at how we're implementing the existing rules, at least as a starter.
Yeah, thank you. I mean, it is within the update that we have put about what the rules are, and now it is NHS England. So I'm more than happy to readdress this, but because we can't alter anything with it at the national level, I don't think it merits an item. I think it's more a case of any updates as they move forward would come through my announcements. That would be my opinion.
Thank you. May I, the other area which we touched on last time was regarding the ambulance, the measurements of the emergency ambulances going to Grantham Urgent Treatment Centre. I know we requested a report that they come back in a year, but my feelings on that particular item, that it would be really helpful to have some feedback from them much earlier than that.
We've had feedback. It's within my chairman's announcements. Okay, thank you. So it has been covered. Right, in which case now, unless there's any other speakers, do we have a proposer that we note my announcements, please? Thank you, Councillor Smith. Seconded, Councillor Hayes. All in favour, please show. Thank you. That's supported unanimously. We'll now move on to agenda item 5, the Director of Public Health's annual report, Ageing Better, Adding Life to Years. This item was circulated as part of the agenda pack on pages 21 to 59. Each year, the County Council's Director of Public Health is required to prepare a report, and this is also presented to this committee as well as other County Council committees. I'd now like to hand over to Derek just to run us through the presentation, and we'll take questions at the end. Thank you.
Thank you, Mr. Chairman. Good morning, everybody. Really nice to be here. As Councillor Macy said, every year I have a statutory responsibility to produce a Directors of Public Health annual report, and the Council has a statutory responsibility to publish it, and I'm really pleased to say that this year the report is actually a joint report between myself and Glenn Garrett as the outgoing Director of Adult Social Services, because we're really focusing on ageing better and adding life to years. You'll remember a couple of years ago we had a joint Director of Public Health report with Heather as Director of Children's Services, where we focused on children and young people's health, especially coming out of COVID. So it's nice to be able to do the other end of the spectrum. What I'll propose to do is just do a few of the headlines and the case and the reason why we have picked an ageing population as the focus for this year's report. A little bit of context about the WHO approach that we've taken. I won't go through each of the areas in detail. I'm sure members have had a read through, and then I'll just summarise and then happy to have a conversation if that's okay with everybody. So, as we've said, the title, Ageing Better in Lincolnshire, Adding Life to Years, is really important. And I've presented this report a few times already, and one of the ways that it can be contextualised oh, we've got a real problem because we've got an older population. I would fundamentally challenge that argument. We have a real benefit because we've got an ageing population, and we have an ageing population because people are living healthier lives. We've got much better health and care systems than we've had previously. Despite all the challenges that we're all aware of, people are living longer in generally better health up to a point. The focus of this report is how do we keep people who are living longer in the best level of health as possible for as long as possible. And recognising that often, and there's a lot of academic work on this, people would forgo a year or two of extra life if the quality of their life as they got older was better. And sometimes, certainly in the medical profession, that's quite a difficult concept to get your head around, because as you're trained in the medical profession, your job is about providing the best care you can to the person in front of you, and generally that's about keeping them alive, of course, as long as possible. And we've got to a point post the establishment of the NHS, World War II, where we're doing that really well. Now we've got to add quality to those years. So that's why we've framed it in the way we have. In terms of adding life to people's years and years to life, that's a multifactorial issue. And the approach we've taken is the World Health Organization Age-Friendly Communities Framework. And that's the picture that looks a bit like a flower, where we've got older people in the centre and we've got a whole range of petals around the outside, each of which describes a key area that we need to be aware of and we need to make sure that we are engaged with if we want to create the environment within which our population can live long and healthy lives. And they cover areas like transport, which in Lincolnshire is a very specific issue for us. And we're doing a lot of really good work in the space of transport, but there's a lot more to be done. And then if you flip that into things like communication and information, the opportunities around digital connectivity is really important there, because one option is to try to get people from where they are to where our services are. Another option is to get our services from where they are to where people are. And a third option is to use digital and technology to connect the two up without actually having to travel. And as a large, rural, dispersed population, you'll remember from the DPH report last year, that's really important. There is no one answer, which is why we've used the Age-Friendly Communities Framework, because each of these petals overlap and interrelate. We outline in the report that we have an ageing population. That's a really good thing. People are living longer. What we're going to see is our over 65 population over the next 20 years or so is going to increase by more than 40%. Again, really good thing. And our over 85 population will nearly double, is the projection. But of course, what that means is we need to change our services. We need to support those individuals to age well and to be as healthy as they can for as long as possible. We then have to layer on top of that the fact that we've got a large rural dispersed population. We have pockets of real high population in Lincoln, in Boston, in Grantham, Louth. We know where those are. But we also have areas of quite high deprivation, again in our major conurbations like Lincoln and Boston, but also all the way down the coast, and Scrutiny Committee will be fully aware of that from previous reports. The reasons for the deprivation are different. Because populations are living in deprived areas, and they are challenged because of that, but the reasons for those challenges are different. And one of the reasons to focus on an ageing population as part of this year's annual report was to say to our service providers and to our commissioners, we need to recognise that. One size will not fit all. One size will not fit all in a small unitary city authority, and it certainly won't work for us in Lincolnshire. We pose the question, are we ageing well in Lincolnshire? And what you'll see there, life expectancy at 65, so if you live till you're 65, if you're a man and you've lived till you're 65, your life expectancy is about 18, 19 years, which is pretty good. If you're a woman, then it's nearly 21 years, which is obviously even better. But then we need to put that into context. For both of those figures, only about half of that time will you live in a healthy state. For half of that extra time that you've got from 65 onwards, you will be dealing with multiple conditions. And of course, what we've got to do is try to stop people getting disease in the first place. That's the whole point of prevention and public health. But for people who've already got conditions, whether it's diabetes, cardiovascular disease or other conditions, we need to make sure that we're supporting them to manage those conditions really well and to live the best life they can. We've also got in the report a little bit of context there, which shows the England average and the difference between our most deprived and our least deprived communities. And as you'll see from there, we're not massively different from the England average, but we are generally below the England averages in terms of life expectancy and healthy life expectancy for both males and females. So there is opportunity there to improve. And when you drill down those data to a lower geography and you look at some of our deprived communities, we're seeing very significant inequalities in some of those data. And of course, that means that what we need to do in those communities is provide more wraparound care than in our more affluent communities if we want to tackle that health inequalities challenge, which is obviously a national priority for the government. Because we've got an ageing population, that's a really good thing. It offers a huge amount of opportunity in terms of civic participation, engagement, workforce. There's a whole range of opportunity, but there are some challenges. The number of people expected to have a fall is going to increase by about 35% over the next 20 years. And in our over 85s, which we expect to double, it's likely to increase by 70%. Now, we are already doing some work around what we do in terms of responding to falls and what we do in terms of preventing falls with a balance and stability programme, which we're funding through the public health grant. And if that proves to be evidence-based and it's effective, then we would want to work with our NHS partners to scale that up, because the more that we do to prevent people falling, the better, clearly, and also to help people understand what they should do if they do fall. We're going to have probably an additional 7,000 people over 65 who are going to be living with a dementia diagnosis. Again, that's a function of the number of people who are getting older. Dementia is not inevitable. There are a whole range of things we can do to reduce the likelihood of dementia, to diagnose it early, and then to treat and support our population to make sure that if you do have a dementia diagnosis, the impact is mitigated and reduced. It is not inevitable. There are lots of things we can do about it, and we have a strategy around that. Over half of 65 to 74-year-olds are expected to have multimorbidity, so that's 4 or more long-term conditions. That can be seen as a good thing. One, that people are living long enough, and two, that we are diagnosing these conditions. But of course, what that means is we've got to manage those individuals as individuals. And one of the challenges we've had with our model of care is we will treat somebody for diabetes, and then we'll treat them separately for cardiovascular disease, and then we'll treat them separately for a third and fourth and fifth and sixth disease. We need to start to have a system that focuses on the person. And we also need to start to recognise that there's a point at which multiple drug therapy is not a good thing. And some of that is the work that we're starting to pick up with our NHS colleagues, and the next item will probably touch on some of that as well. And of course, with an ageing population, the role of our carers is absolutely fundamental. The NHS, social care, the whole public sector in Lincolnshire and across the country would fall over tomorrow if we lost our carers. So we've got to continue to support our carer workforce, people who provide unpaid caring, and we're expecting that our unpaid care population over 65 will increase by about 30%. So all of the work we're already doing, we just need to keep doing, and we need to scale it up if we want to make sure that people live long and positive lives. So that's the context as to why we focused on the areas that we have. I won't go through each of the separate petals on the flower, but hopefully everybody's had a look at those. They cover things like community support and health services. We need to clearly change our models of support and care. Respect and social inclusion, making sure that our older population and our ageing population are fully embedded within our societies is fundamentally important, not just for them, but for the society themselves. Our communication and information often needs to improve very significantly, and that's a two-way street. That's not just how people receive their information. It's also having some open and honest conversations with the people of Lincolnshire and the people of the country. As Scrutiny will have heard me say before, we're spending £1,600 million on NHS services in Lincolnshire alone next year, and it is not enough. The idea that we can carry on the way we are is not accurate. It's facile. We cannot carry on doing what we've always done and expect to get different outcomes. We are going to have to change our system. We're going to have to change how we support people, and we're going to have to work with the population about what they want and where they get that support. Social participation is another key area, and civic participation. And you'll notice that there's a recurring theme across these petals about engagement and participation. Absolutely vital. One of the key tenets for public health in terms of having a healthy life, and you can have a healthy life even if you've got multiple conditions, is everybody needs a home, a job, and a friend. Now, clearly, if you're in your 80s, you may have had a job for a long time and you don't want a formal job. But participation, civic participation, engagement is really, really important to have a good life. We have real benefit in Lincolnshire around our outdoor spaces. We've got masses of beautiful countryside, masses of blue space, whether it's the coast or whether it's our rivers. So we can use that better, and that has a massive impact in terms of both physical health, getting out into nature, and mental health, which is obviously a key interest for members of Scrutiny as well. And I've already mentioned transport. Just to wrap up, I think the analogy of petals on a flower is really important, because we put in the report how we can't look at the role of housing in terms of improving the health and well-being of our ageing population without understanding transport connections. We can't understand transport connections until we think about how we use digital and technology and other information resources to connect people up. So all of the different petals on the flower are vital, and they are interconnected, and we describe that in the report as well. The recommendations really are key for me, and as the Director of Public Health report, these are the things that I'll be taking into conversations with our councillors, like yourself, with our NHS partners, and I'll be presenting this with our district councils as well. They are things about social isolation. We need to connect up our communities. They are transport. We're working really closely with our transport team here, but it's not just about the public sector transport offer. It's about what families and communities can do for each other. We saw this with COVID, didn't we? Digital inclusion is absolutely vital, and we're doing a lot of work with the university around how to think innovatively and differently about how we include people in digital, because it's not just about whether you've got broadband, it's about whether you've got a phone or a laptop. It's about whether you're educated enough that you can use that and maximise the benefit. Wi-Fi connection in the council chamber being a good example. You know, there's lots of stuff. It's not just about having a mast up that gives you connectivity. And our housing stock is absolutely fundamental to this. And that's where we're working very closely with our district council colleagues. I shall finish there. Happy to answer any questions and have a conversation.
Thank you for your presentation. Councillor Parkin first, please.
Thanks, Chairman. Derek, I really liked the report. I liked the fact it considered a real holistic view of ageing. There's two kind of, one question and then one observation, really. The question is, falls prevention, for me, yes, obviously at the moment we're having to target that generation who are likely to fall. But do you think moving forward there is scope to be targeting the 50-year-olds, the 60-year-olds, and be talking to them specifically about how they prevent it? Because in fact, the best prevention starts at my age, in my mid-50s, as opposed to waiting. And then how would we do that, and what will be your long-term view of how we then go about getting that message to those people? And then the second one is, really this comes into my, under the hat of my new role as a funeral celebrant. I probably should have declared an interest. No, it's not. It's a vague one, I know. But what I'm finding is really hitting home to me, and it makes me incredibly sad, is that we are looking at people. You mentioned specifically in the report losing a spouse, which I recognise is huge, but I am meeting people who have lost, they're in their 90s and they've lost children, multiple children who have passed away in their 60s and 70s. We are looking at people who have lost multiple close friends, multiple close family members. So in fact, it isn't just about having lost a spouse. It's having suffered severe bereavement, sometimes 4, 5, 6 times a year, over a number of years. And each one is different and each one is new. And each one comes as a new experience for that person. And I think we probably need to widen our view as to what bereavement for that generation means. It isn't just about losing a partner.
I'll come back on the falls prevention first. So I absolutely agree, of course I do. Primary prevention, stopping people falling in the first place, is the most important thing that we can do for a long-term benefit. And you're absolutely right. I'm in my 50s as well, and balance and stability is really important. So I've got back into weight training, I've got back into gym work, not because I particularly like it, but because I can see that I know the benefit over a long term. But there are some relatively simple things that you can do. So, and I think we've spoken here, or it might have been adult care scrutiny, about when you're brushing your teeth, standing on one foot for the first minute, and then, because you should be brushing your teeth for 2 minutes, I hope everybody knows that, twice a day at least, but stand on one foot, and then after a minute, stand on the other foot. That has a very strong benefit in terms of balance and stability, and it builds strength. There is a lot of core work that you can do that's going to help reduce the risk of you getting a bad back or a bad neck. So there is a really important aspect, as you've said, around what we can do for ourselves in our 50s, our 60s, our 70s, our 80s, our 90s, and onwards, actually. But there's also an environmental question there. So in terms of falls avoidance, for scrutiny members who've been around long enough, you might remember sloppy slippers and programs like that. There are some, if people don't have proper slippers and they just, their heels are out, then it's a trip hazard. If they have rugs lying around, then it's a trip hazard. There are some physical environments within your own home that you can recognise and change that reduce your risks. So it's all about building your own resilience and strength and reducing your risks. And I think those two are really important. What we're doing with the Balance and Stability programme is some academic work I've been involved with for 5-7 years with the University of Nottingham is about, we know what works for people who are at a much higher risk of falling and frailty. And it is basically chair-based exercises, but quite intensive over a long period of time, massively reduces your risk of falling. And obviously if you fall and you maybe break your hip and you end up in hospital for a long time, often that can start a downward spiral. So we've got to work right the way through the entire pathway. For people who are in their 50s and still reasonably fit and healthy, how to maintain it, how to reduce your risk, right the way through to people who've already had a fall, how do we stop them having a second fall? And that whole pathway is really, really important. But it basically comes down to balance, stability and strength, all of which we can support ourselves and each other to develop. In terms of the bereavement point, I think you're absolutely right. Having older relatives that we all may have, it is quite a challenge. And seeing loved ones, obviously, end of life is a real challenge. I think it's a societal change, isn't it? Some people will live into their 80s, 90s and hundreds, and how we support them is really important. At the moment, we focus on spouse as part of the wellbeing service because there's a lot of evidence that if somebody loses a spouse, then they are at risk of needing a whole range of support if we don't go in and support them early. But I think you're right. There'll be lots of other evidence coming forwards about other key risks that we need to think about.
In terms of the fall, sorry, I should have included this in my initial question. Domi. Been talking about it with all of my parish councils, with Legbourne parish councils, and the question from them was: is there some kind of they have a publication every week that they pay every quarter that they post through people's doors. Is there a kind of oven-ready false prevention leaflet that could go out with that? Because if they're posting that, I mean, obviously, you know, Legbourne has a very high elderly population, and they were just wondering if there was something that they could just get distributed easily. And it might be a good thing for all of our parishes to do anyway.
Happy to pick that up outside of scrutiny, and we'll make sure that there's lots of resources online, and also our integrated lifestyle service, One New Lincolnshire, which you'll remember does a really good job and has been independently evaluated. They are the provider of the falls response, sorry, not the balance and stability programme, but you have to be referred into that by a professional. Yeah. So if you're after the more general stuff, I'll pick that up with you, and we'll do a little piece with John and make sure that we get something with some of the national evidence on that. Yeah.
Thank you. I've got Councillor Allen next, please.
Thank you, Chairman, and thank you, Derek. It was a very interesting presentation. Indeed, the report is very good as well. In terms of identifying the things that can take place to maintain that initial healthy period in older age before health starts becoming perhaps the predominant factor. And the whole idea of adding life to years, I think, is quite important. I do worry about how all these various things can be brought into play as, in a way that actually does that, because underlying that there is the health issue, I think, in terms of allowing people to actually add the life to it. And I think the other thing that we shouldn't forget is that we also need to add years to life, and at the moment life expectancy is actually decreasing. And that's probably as a result of the health issues becoming prevalent, maybe, to a great extent in terms of the elderly population. But that doesn't mean to say that we shouldn't try and prevent that and add the beneficial aspects of life to it. I've only got one question for you, really. That was just a lead into it. Can any of this be delivered with the state of the National Health Service as it is at the moment, and the capabilities of the National Health Service?
So the answer to that is yes, absolutely. I wouldn't do this job if I thought we weren't going to improve the health and well-being of the population. And I'd go back to the argument that when you look at the establishment of not just the NHS, but the social care system and the five giants that came out of World War II, we have seen a massive improvement in life expectancy. You're absolutely right, it has stalled, and we need to improve that. We've seen a massive improvement in life expectancy. We've seen a big improvement in healthy life expectancy from World War II, but we have stalled, and we need to reinvigorate it. I think I mentioned when I was doing my presentation, the idea that we're going to do it within the current model is, I think, wrong. We have to redesign our model of health and care. And that is right the way through from national government in terms of the national policy, through to what every individual in Lincolnshire does for themselves to support themselves and how we support each other. And it's right the way across. We'll also need to recognise that what we as people want is not necessarily what we as people need, and that's an important conversation. And there's a cost to all of this. And where do we want to, and how do we want to fund the system? So the really, really massive debate I think we've got to have as a country. But I'm absolutely positive that we will have that debate, and I'm absolutely certain that the outcome will be better, longer lives for the people of Lincolnshire. It's hard work, and Pete and I are going to talk in the next item about the strategies and both the what we want to do and the how we want to do it, which hopefully will start to answer that question.
Right, Chairman. I only asked one question. Maybe an important one. I like your confidence in terms of the initial part of the response, Derek. You know, absolutely. I'm quite sure that absolutely that you should be able to deliver this in terms of not only providing healthy lives through older age, but actually ensuring that the healthy part of old age is a lot more beneficial perhaps than it is at the moment. And the sort of things that you've identified all go into that, although I did think Councillor Parkin's point about dealing with the loss of spouses and the loss of friends and something like that, that's probably as equally important as we get to the latter parts of our lives, and should not be ignored. Probably as important as ensuring people go on walks and things like that almost. Although you did qualify your confidence in terms of not with the model that we've actually got at the moment, and that's what worries me. It's the model that we've got at the moment that doesn't seem to be helping dealing with some of the aspects that we have to deal with, and in the underlying issues that affect old age. So to allow us then to put in the prevention issues and the healthy aspects. And, you know, it's all very well, you know, trying to do all these sorts of things that you're talking about doing, which need to be done. But it's not going to have a great deal of success for somebody that's waiting 3 or 4 years for a hip replacement or whatever it is. Because unless you have the hip replacement, you can't do many of the sorts of things that you're talking about. And that's just one aspect of getting improvement, should we say, in the healthcare that's got. Never mind the social care. I didn't mention social care. But it's part and parcel, I think, of the health system that we ought to be operating. And I think until we address that, as well as putting these sorts of things into place, we're not going to see the improvements we need.
Okay, thank you. I've got Liz next, please.
Thanks for your presentation, Derek. It's really insightful, and particularly as we're all getting older. So pleased to know that I'm still contributing into the community. But from a Health Watch perspective, a couple of things resonated with me that you said is around maybe not people having as many medications as they need when they're older. And one that I think you mentioned that if somebody was to choose to live and they'd sooner have one life less if it was more fulfilling, which led me to think about how do we potentially have some conversations in health and social care environments without sounding ageist, when it might be in an individual's best interest to stop or reduce treatments for their lives to be more fulfilled, without necessarily people interpreting that it's just because I'm old that treatment's been stopped. So just some thoughts on that, please. Thank you.
I'll bow to your superior knowledge, but my answer to that would be we need to listen to people, because I think as people get older, generally they do become more they broaden their thinking out about the quality of life. And I remember when I was wet behind the ears training in public health, I did a global burden of disease training course, which was run by Harvard University. You might remember we used it for a DPH report a few years back. And that very much focuses on years of life lost and years lived with disability. And a lot of the academic work, and this was in the 90s, around that they call it a time trade-off. How many years of extra life would you trade to improve your quality of life over the next 5 years was already there. The evidence is really, really strong. And this is, this was Harvard University, this was WHO, I did it in the US. Really, really strong evidence that the vast majority of people would trade, but we haven't set up our health and care system to recognise that and to have those conversations and think about what a good life to people is, rather than what's a good clinical outcome in terms of your diabetes. And that's a really different question. And if I may go a bit big picture now, I do think we're at the point now, because of technology, because of just what a good job we've done with the welfare state from post-World War II up to the beginning of the 2000s, we need to have a refresh and a rethink. We've got to, and it's not just about older adults, it's about our education settings. It's about our workforce. It covers all the 5 giants, as were outlined in the welfare state model in the first place. That's got to be the conversation. And then you come down to a very specific conversation, which might be between a doctor and someone who's got lots of different conditions, about you're on 20 tablets a day. Is that right for you? And the vast majority of people, once they're given that power to have that conversation, will have an open and honest conversation and will tell clinicians what they want. And we've got to respect that. So I'd go back to, we've got to start with the people. We've got to start with the people at individual level, and we've got to start with a national debate as a country.
Okay, thank you. I've got Councillor Smith next, please.
Thank you, Chairman. There is a point made in the report about how organisations communicate with people, and that's very important. But I think what's also vital to note is that it's not just those who are older that have issues with the increasing digitisation of communications with respect to, say, for example, the NHS. I'm 29, so I'm not. I'm quite young. I'm not as young as I used to be, but I have a vehement dislike to being forced to down a digital pathway. Oh, your appointment. Oh, we'll do. But I'm the patient, and I'm telling you that isn't going to work. But I have to fight to say, you can't assess my medical condition by a digital means because you can't see me walk through a telephone. I also don't have the internet that's decent enough to have a decent connection for you to do that. So there's a total disconnect between actually what's the practicalities on the ground, especially of rural Lincolnshire, to what organisations want. And it's not just the NHS, it's every walk of life. It's, oh, well, we'll do that via a digital means, by a Zoom or telephone appointment. DWP is another one. It's, oh, well, we'll do your assessment by phone. That's great, but you can't see the pain I'm in. You can't see the distress that something's potentially going to cause. And we need to have a real, honest conversation of, yes, it might say, and even at the county council to a lesser extent, yes, it might save us some money, but in the long run, is it saving us money? Because are we actually delivering what we're supposed to deliver, and are we getting it right first time in the first place? So there's got to be that balance. Secondly, Derek, and thank you for mentioning this, you rightly said we can't carry on in the way we are regarding how much that we spend on health and what we're and the model and what we're trying to deliver through it. But you mentioned we need to change. But what do you think that change is potentially with less money? Let's be honest. That could be a real possibility, especially if the reports around the fact that we're in recession are to be believed, and competing priorities around local government, defence, and everything else. As you say, go big picture. And I'll just make one final point with your indulgence, Chairman, around what Councillor Parkin said. And this may sound morbid, but it's relevant. Most of my friends are considerably older than me, and I'm not talking 5 or 6 years, I'm talking 10 or 20 years. So by the time I'm 50, and I'm tragically already lost my father, but by the time I'm 50, I could have been to 20, 30 funerals and have 1 or 2 people left who actually know me, who are friends with me, and that's 50. So there are a lot of people who will be in that position. So as Councillor Parkin said, I think we need to go far, far beyond spouse and immediate family. It's actually when somebody is in my situation, what do you do? Because when you go through that, you get to a point and you think, well, nobody knows who I am. I'm on my own. It becomes very lonely very quickly, and then you will have a mental health issue potentially. So it's how do we deal with that? And I also like the point that was made around having that conversation around sort of good years and medications. I know we've discussed that, Chairman, before, and that is still a real problem. And again, I'll use myself personally, Chairman. I have still not had, this is 3 months now, and I still can't get hold of my medication for my epilepsy. I've luckily got a bit of a supply, but that is getting smaller. That's having a huge impact on me, because eventually if I run out, it'll be, oh, well, I'm supposed to take it X times, well, I'll have to ration it, which is dangerous, because if you ration it and you drive as I do, you could potentially have a seizure, you could have quite serious repercussions. So it's not just having that conversation about what tablets you take and why you take them, it's making sure actually we can get the tablets we need to live and function and live well in the first place, which currently, Chairman, as you know, let's be honest, in a lot of cases, be it epilepsy in my case, be it diabetes, be it ADHD, we're having systemic, real problems with that. And I know that's not necessarily for you to answer, Derek, but it's important that that is in the conversation, the debate, Chairman, that it's not just how many you take, it's can you get them when you need them, and why do you take them? And to finish, Chairman, on that very briefly, I think that the conversation is right, Derek, that you have to have that with patients, but for mental health, certainly from experience, be it professionally and also personally, patients are forced down a pathway of there is one type of therapy, if that doesn't work, there's the tablet, go away. And that's certainly my experience, that's certainly an experience I've had mimicked with a lot of people I've helped. And the system to remove yourself from that pathway is not there in the National Health Service. I was lucky, I had a very good friend who was Royal Army Medical Corps, and he helped me off the medication I was on at the time, because it wasn't actually doing what it was meant to do, it was a sticking plaster. But that's luck. I would have been left otherwise for 2-3 years, however long, on these tablets, and possibly for life, which, as you've already said, actually long-term wasn't good for me. It was actually harmful. It did the initial thing it was meant to do, but long-term was very harmful. So it's how do we, as you say, do that big picture conversation, how do we actually get it to work in practice?
I'll just reflect on a couple of bits. I think, Councillor Smith, you've given really good examples of both ends of the spectrum, you know, your personal experience and how we need to be, as a system, far more responsive to an individual's needs, not a particular clinical need, and really salient examples there, through to how do we deliver our health and care system that's different for the future. And I think the fundamental question there is, as I said, £1,600 million from the Integrated Care Board in 24-25 is the budget, 220 million in terms of social care via the council, probably a similar amount in terms of wider support for specialised services from NHS. So in Lincolnshire alone, probably £2,000 million is spent every year. 2,000 million. We say 2 billion, but let's just break it down into a number that you can't get your head around, but it's clearer. 2,000 million pounds for 750,000 people in Lincolnshire, and it's not enough. So the question is, do we want to spend more and more, and if so, how? How are we going to fund it? Or are we okay? Are we going to grasp that nettle and redesign our system within that financial envelope and do things differently? And that's everybody. That's clinicians, that's managers, that's people like me, that's people like you as politicians, but it's the general population and how we use that money and that resource. That I think is, for me, the big question for the next decade. And we've got to come up with an answer, otherwise we will have a very different system. And again, if that's an open and transparent conversation nationally, then fine. But we've got to have that conversation, in my view.
Thank you. Conscious of the time now, and I've still got 6 speakers that want to come in. So, and now a 7th. So what I will say is, if you can just ask a question only, and no anecdotes, please. They can be useful, but at this particular point, we'll not get through the morning if not. So I'll now move on to Councillor Kendrick, please.
Yes, thank you, Chairman. I was interested in your comments about health, what we might call health promotion issues, and the examples you gave were very interesting. I was just wondering what active outreach there is. I can think in my division, I know of a number of groups of people over 60. In fact, I'm a member of an over 60s group, which has 100 members in one village. But I have no idea or no knowledge that there's been an active outreach from our services to groups such as this to spread the information, such as even the anecdote you gave about brushing your teeth standing on one foot, and things like that, which could be communicated to groups. And I'm sure members here could participate in identifying groups that could receive this information, as Councillor Parkin has mentioned on bereavement. And I just wonder if there's a process we could develop whereby members and officers can identify groups within the community, and there are databases which have these groups listed, where there could be active communication rather than being a sort of reactive approach. Thanks, Chairman.
Really good point. I think there are some really good resources out there already, NHS Online being the primary one. it is actually going to come into the next item about how we connect with our communities and inform and support our communities. So we'll pick it up a little bit there, but really happy to do something in the meantime. I'd also point members to the Connect to Support website. I plug it every time I come. That does have all of these, well, doesn't have all, but it has a huge number of local groups that individuals can connect with and get that support. But then supporting those groups, I think, is the point that Councillor Kendrick's making, and absolutely we'll pick up on that a little bit in the next item.
Thank you. I've got Councillor Cleaver next, please.
Thank you, Chairman, and thank you, Derek, for the report, which, as always, is an interesting read, very thoroughly compiled, and obviously impressed by the holistic approach. I'm interested from the point of view of someone who is an active division member, and I pick up a lot of feedback from local residents about health issues. Obviously, there's a tremendous consciousness that we have an ageing population, and that we are rationing scarce resource. Healthcare is a scarce resource, which has to be compassionately and efficiently rationed. We're all aware of that, and I think we're all aware of the need for health education. So I'd like to pick up a little bit on the points that you make about housing and transport and digital inclusion, because all of those, with communication, link together to how people actually access healthcare, primary healthcare, but also health advice to prevent them from needing the healthcare. And I would just make the comment that those things actually do link together, because if you don't have transport, don't have digital inclusion, and we've not got the communication, the outreach, which means that they can access the assistant, access the advice, and access the care, then it doesn't work. And in the that linkage doesn't come across in your conclusions, if I may say so. But it's something that I pick up all the time. People say the only way I can communicate or get health advice is picking up the phone and waiting for half an hour for my GP to answer. I can't get the GP to visit me anymore. Now, you know, most people would say, if they're in a rural area, that's social exclusion. We don't do things like, as far as I'm aware, I know PCNs cover well providing services for care homes, and that was well documented, and I think it came through during COVID. That's a very necessary service. What I'm not seeing, and I'd love to see, and correct me if I'm wrong if it's already going on, you know, I'm also a district councillor, and we have a lot of sheltered housing in my division, but those people aren't given access in their shared areas to people coming along from the PCN and giving them health advice and saying, when you brush your teeth, stand on one leg. I'd love them to have that sort of access, and that's about their housing. It's also about the fact that if they are on the internet, they may not be able to know those things either. I mean, it's an interesting point. I like the point you made about the standing on one leg while you're doing your teeth, because you can then think, how would anyone find out about that if they're not listening in now online? You know, is someone going to go to their sheltered housing and tell them? Are they going to find it out online because they're not they're socially included, digitally included, or are they going to have transport to somewhere where they will find it out? You take my point, and I think that it's something that we need to think very carefully about, because that I pick up all the time. I feel excluded because there's no way of communicating with me through my housing, through my transport, and through my digital inclusion.
I'm conscious of the time, so I think part of the answer there will be in the next item, because in the health and wellbeing strategy, housing continues to be one of our 5 key priorities. And in the integrated care partnership strategy, digital and technology is one of our 5 key enablers. So we can talk a little bit maybe there about some of that. I would pick you up on a point though, which is I can't get my GP to come out to see me. That's the model that we used to have. GPs go through 7-8 years at least of training of very expensive resources. Do we need a GP to go out and see you? Or do you need somebody who's maybe a physiotherapist? Do you need a nurse? Do you need somebody who's a profession that we haven't created yet, who can help? that we can have 4 of, that we'd spend that money on one GP. This is part of that conversation. What and how do we support people with the right information and advice and support, and the right clinical input at that point? I know it was an example, but I do think that's part of the. We've got to change our narrative about what's the problem we are trying to fix, and I speak with reference to my GP colleagues. Most of the time, it ain't a GP that's going to fix it for you.
Apologies, I misspoke. I meant a home appointment from a primary care healthcare professional. Apologies.
Okay, thank you. I've got Councillor Matthews.
Thank you very much, Chair, and Derek, thank you very much for your report. Yesterday, it so happens that I was listening to Professor Chris Whitty speak about his last year's annual report, and he drew attention to a slide, and I hadn't realised, despite the fact that I read it, how stark this information was. And it's about inequality in life expectancy and healthy life expectancy at birth for females in the most and least deprived areas in England. And this is strong data. The most deprived 10% of small areas have 51.9 years of good health. And then they have 26.4 years of poor health. And their life expectancy is 75. The least deprived 10% of small areas have 70.7 years in good health, and then 15.4 years in poorer health, with a total life expectancy of 85. His data highlights the extent to which our rates of biological aging, and you clearly picked up, is far from fixed compared to our chronological age, and demonstrates improvements in quality of life in POS, which is what you're doing. He goes on to say, though, ill health is more concentrated in some parts of England. There is a great proportion of disease and disability in some rural and coastal areas. This is partly driven by age structure and partly driven by concentration of deprivation. Now, you will know that we probably, and I'm making this up, I don't know it's a fact because no one's checked it, have probably got the longest coastline of any local authority in the country. If you think about it, it runs from Long Sutton, Boston, through Boston, back to Skegness, all the way up to Cleethorpes. I might be wrong, but it's pretty damn long anyway. It's not the longest. That seems to me a national inequality, because the national health funding is based on population. You know, so much money for and we don't have that population. But within that, we've got a much greater proportion of people who are not aging well and having a fairly torrid time. I wonder what we can do to address that, because the data is strong, absolutely strong. It's being raised at a national level, you're raising it. But what more can we do to bring attention to that criteria referenced funding, because it's not working in Lincolnshire?
Yeah, I agree with all of that, as you would expect, Councillor Matthews. I think the Chief Medical Officer did a report previously, as you know, about rural and coastal communities, and actually came to Lincolnshire, and we were a case study, as was North East Lincolnshire, so 2 of our upper tier authorities across Greater Lincolnshire. And I did a DPH report. I'm sure Chris just finds out what I'm doing and then copies me, but don't tell him that. Because this year's was about an older population as well, and we'd already started ours before he started his, so that's my argument. So yeah, we're absolutely in check. The index of multiple deprivation and the funding formula that the Department of Health and Social Care uses tends to be urban focused in terms of urban deprivation. We are making that case. There is now an index of rural multiple deprivation that accounts for things like trying to deliver services in a large rural dispersed community, but the government haven't adopted that yet, so we continue to make that those representations, and I would suggest all members of Scrutiny as local politicians continue to do so, because you know, Lincolnshire and other rural communities and coastal communities are different, not least because if you live anywhere near the coast, you can only look inland unless we start delivering services on boats. It makes it quite difficult in terms of service delivery models, and that's more costly, and that's not recognised currently in the ROCA formula and how we are funded.
Okay, thank you. Councillor Morgan, please.
Thank you. Excellent. It's an excellent report, and I suspect we could actually spend all day talking about it. It's so interesting and covers so many areas, and has been said, really holistic. I've got a number of areas which I will cut right down. I'd like to touch on, it's been mentioned housing, but I think housing quality and the issues we've got around that. One of the things that really strikes me as the district councillor with some very poor quality housing in my ward, private rented accommodation, is how we're stuck. Because an obvious solution would be to actually start enforcing some of the existing rules and laws that we've got around making landlords improve the quality of housing. But the flip side of that is actually that landlords are turning around and saying, well, actually, I don't want to be a landlord anymore. And I'm seeing this quite frequently. So actually, homelessness is becoming an increasing risk across the whole spectrum, regardless of age. And I have noticed actually people who are in their late 50s, perhaps single, seem to be particularly hit, maybe where there's been a divorce and they've ended up living on their own later in life. So my concern is, how can we work with other agencies, the government, etc., to really seriously look at this, because the knock-on impact on everything, mental health, physical health, etc., is so big if we actually continue to have people living in substandard accommodation. The other thing around that is that I don't think we're reaching those people. One of the things that really strikes me when you look in the community, we've got some really good charities out there touching people, but I'm glad that outreach was mentioned. What strikes me though is we don't seem to be, some people seem to get access to everything and know every organisation going and every pot of money going, and then you come across somebody living on their own, usually at home, who have no idea what is out there, and you feel like a proactive approach to them is needed rather than expecting them to come. And then that leads to communication. I think it's really interesting. I've just received an invitation to a really posh 2-day event talking purely about introducing more digital into local authorities, how we'll be more efficient, how we'll be more effective, etc., how to introduce AI, all the things that actually cut against what we're really being told in this report, which is actually people want face-to-face contact. They want to read something come through their letterbox. So I'm really concerned that the amount of pressure that's on local authorities and all the public bodies been touched are all driving us down a let's save money route rather than actually serving the needs of our community, and especially our older community. And if I add to that, I am aware adult literacy rates are actually really, really widely vary, and we have a significant percentage of the population, I think it's about 20%, with a reading age of less than 7. Less than 7. When you think how much we are relying on people to read, whether it is through the letterbox, whether it is online, that really worries me. They are being excluded, and probably most need access to our services. So I don't know what your thoughts are about that. Thank you.
I agree with everything that you've just said, Councillor Morgan. I think in terms of housing and housing quality, we'll pick up on the next item, because we have that as a priority, and we have a delivery group that's actually chaired by Councillor Bowkett as the lead councillor as well, the portfolio holder, which brings together all those partners that you've spoken about. I think the role of the third sector is absolutely fundamental, and again we can pick that up because that's a fundamental part of what we're doing as an integrated care system, and we have really strong representation there. But we can't expect community and voluntary sector organisations to deliver for free what we're wanting them to, or what currently we're trying to deliver. That's important. The argument that those people sometimes who need it the least get the most is absolutely right, and is evidence-based, and is called the inverse care law, and is all about people who are educated and affluent and connected, stay that way and make sure that they get what they want when they want it, which is not the same as what they need when they need it. And people who need more often have less access, and that's a fundamental question. But I think the communication aspect is a common theme. And the DPH report is obviously about raising issues and making recommendations. Hopefully the next item will get into the "and so what are you doing about it" question, which I think is perfectly reasonable.
Okay, thank you. I've got Councillor Haigh.
Thank you. Thank you, Derek, for your report. I'm going back to when you were talking about going into the gym and doing exercises at home. What you didn't touch on was just going out for a walk, how beneficial it is both mentally and physically. I mean, I've had non-Hodgkin's lymphoma 4 times and had a lot of treatment, and I started after treatment or during treatment walking around my garden. I mean, I can walk 2 to 3 miles now. Now I've got another friend that when COVID struck, she did walk with us and didn't do anything, and now she can't walk. So, you know, if you don't use it, you lose it. And also, you know, to join walking groups, it's just so beneficial. What do you think to that?
I absolutely agree with all of that. You know, use it or lose it, I think is a really good phrase. The benefit of walking in terms of balance and stability, in terms of core strength, in terms of cardiovascular strength and wellness, but also in terms of mental well-being, and especially if you do it with a friend, a loved one, or a group of people you don't know, and you start to connect that way. It ticks so many boxes, it covers so many petals on that flower. You're absolutely right. And I think in Lincolnshire, to be positive about where we are, we've got such great countryside, such great green space, blue space that I did mention in the presentation. The more that we can use that, the better. And you look at other parts of the country and they do use those facilities. So yeah, absolutely agree with everything you've just said.
Thank you, Derek. Thank you.
Thank you. I've got Councillor Parkin again.
I'll be incredibly brief. Just to back what we were saying earlier, I am meeting with families all the time where loved ones themselves are making the decision about what medication they're stopping. And they are proactively already having those discussions that the side effects of this are not worth it, I'm not taking it. And so what you then end up with is they then are collecting the meds, and we have people with cupboards full of unused meds. It's complete waste, but people are making that decision all the time. And secondly, just to double check, when you talk about the spouses, if you've got a spouse, you can access that support from wellbeing. Please tell me that spouse or partner.
Okay, thank you. I've got Councillor Mackinson-Saunders.
Thank you. I'm probably going to be the only person that says I'm fed up. I've got a vested interest in older people, obviously, but I don't think we're attacking the right generation, because you can't have a good old age if you don't have a better middle age. And I do agree with what Sarah said about that. And I'm always going on about, I run a baby bank, the scrambled lives that younger people live. No wonder they get ill and all the rest of it. And I think we need to address those problems in a very different way. And we need, we need to teach people to eat I sound horrible now because I sound really old. But we need to teach people how to eat properly, how to cook, how to probably save a bit for your old age. I'm lucky and I go and do lots of sports still, and I'm old. But you do need to be able to pay to go and do that. And if you're living on the breadline, well, a lot of it you need to go and pay, because nobody does anything for free these days. And I think we need to encourage people to live better lives. I went to a presentation by the local dementia group just recently, and they said 40% of dementia you can save 40% of suffering from dementia in later life by living your middle years properly. And there was a little thing of 12 different things, and I mean they're all the sensible things like eat properly, don't smoke, don't get diabetes and all the rest of it. Yeah, have exercise and all the rest. But those are common sense, and I think I'm jolly glad you're looking after us old people, but I think we need to target a different generation and help them to live a better life. And one thing I'll say about death. Death is part of life, and I think we encourage people to be anxious about life, where they probably shouldn't. We've set up, through a new group that I'm involved with, and at the advice of the two guys who work in our cemetery, who like to speak to people up at the cemetery who come to grieve, but they weren't really sure how to do it. And we've set up a new bereavement group in Nath, and it works really, really well. And we've got an 87-year-old vicar who looks after it all, but he's advising the younger people, and younger people are getting involved. And I think I'm lucky to live in such a nice community. And like the councillor over there said, going out for a walk. But we all speak to each other when we go out for a walk, and people stop and look at the dogs and things like that. But I think there's so much about community, but there's so much about living your middle years in a better way. And, you know, fairer funding and all the rest of it, thumbs up to it all. But next year, can we address those problems of a different age group? But thank you for looking after my age group.
Yeah, I sound like a broken record. I agree with everything you've just said. This is not an either or, this is an all. And as I said a couple of years ago, Heather, as a Director of Children's Services, and myself did a joint report just around children and young people. So you're absolutely right. My remit is from cradle to grave, just like Beveridge. So I completely agree. We need to get every part of that system right. What we do know is that in terms of health service utilisation over a life course, it's pretty high right at the beginning of life, and then the vast majority is towards the end of life. So in terms of creating the space in a system to do things differently, we've got to do the older adult part better. Stop people getting sick, manage their sickness better, help with end-of-life care better, to create the headroom, unless we all want to put a lot more money in. We've got to do that bit right to create the space to then change the rest of the system. And that's true in terms of the overall budget, but it's also true in terms of some people, and a lot of people, are quite happy with digital online appointments. And if we do that better, we're going to create the space for people who need face-to-face appointments to have those face-to-face appointments. So it's about efficiency and effectiveness as well.
But it does feel like we're creating a worried well a lot of the time these days. And that's probably why we can't get doctor's appointments. But if you've got a secret for that, perhaps you'll let me know.
Councillor Wotton.
Thank you, Chairman. Thank you for the report, Derek. I've just got one comment. On page 51, you've got costs for home care, and I've been looking into this for a family member, and it's quoted at £15 per hour. Wish it was. But then I see your source is Age UK 2021, whereas on page 50 you quote cost of residential care, which I would say is more in line with what I've discovered, and it's Age UK 2023. So perhaps you could just look at that figure or whatever. Thank you. Thank you, Chairman.
A very specific point. I think those data were the most up-to-date data we could get at that time that were in the public domain. I absolutely accept that there's a whole range of different costs. They're sort of the average costs, and they will be different depending on the requirements, and actually the geography, picking up some of the travel issues. We do reflect that in our rates as a council, as I'm sure you're aware, through Glenn and now Martin's work as the Director of Adult Social Services.
Okay, thank you. I've just got one question I'd like to ask, please. And the recommendation on promoting subsidised hospital transport and expansion of the voluntary car schemes on page 31 of the report and page 53 of the agenda pack is very welcome. But how do you see this being taken forward in the coming months?
So again, we'll pick this up probably. It's a nice segue into the next item. We need to start thinking at a system level. We need to stop thinking as the council, as the NHS, because the NHS isn't the NHS, it's lots and lots of different bits. And also, we've talked quite a lot about voluntary and community sector and their role in delivering support, and we've got to refocus how we do that. So we'll probably pick it up a little bit through the integrated care strategy work, if that's okay.
Okay, in which case I'm going to make a proposal. My proposal is that the committee welcomes the annual report and supports the 5 recommendations, and in particular the committee would like to record its support for the recommendations on promoting subsidised hospital transport and expansion of the voluntary car schemes. So I have a seconder to my proposal. Councillor Wootton, thank you. All those in favour, please show. Thank you. That's supported unanimously. Thank you. And thank you for
Mr. Chairman, could I make
Yeah,
a point
Councillor
there?
Christensen.
Because the voluntary car scheme, you have to pay the money up front, and a lot of people struggle to actually find enough money to be able to pay the driver there and then. Is this addressed by this?
Derek, I don't know if you'd like to.
Yeah, it's a recommendation at this point, so we need to get absolutely into the detail and figure out with partners how to update the scheme, expand the scheme, and make sure that it's inclusive and actually targets those people who really need it. So, really good point. It's one of the areas that we want to pick up.
Okay, thank you. In which case, we'll now move on to agenda item 6, the Joint Health and Wellbeing Strategy for Lincolnshire 2024 and the Better Lives Lincolnshire Integrated Care Partnership Strategy. This item was circulated as part of the agenda pack on pages 61 to 106. This item comprises of 2 high-level strategies which are due to be approved on the 12th of March, in one case by the Health and Wellbeing Board and in the other by the Integrated Care Partnership. I'd like to welcome our presenters in person, Derek Ward, once again, Director of Public Health for Lincolnshire County Council, Pete Burnett, Director of Strategic Planning, Integration and Partnerships for NHS Lincolnshire's Integrated Care Board, and Alison Christie, Programme Manager for Strategy and Development for Lincolnshire County Council. I'll hand over to you for a quick run through the presentation. We'll take it as read and then take questions at the end if we might. Thank you.
Thank you, Chair. I'm sure everybody's sick of hearing me talk, so I'll try and keep my bit as short as possible. I'll pass over to Pete as well to talk about the Integrated Care Partnership Strategy. And Alison's our resident expert and has done all the work, so the conversation will probably be really important. The covering report describes why we've done it this way, which is that we have to have a health and wellbeing board and we have to develop a health and wellbeing strategy that's based on the Joint Strategic Needs Assessment, which is the evidence base about what are the priorities in Lincolnshire. Scrutiny will be fully aware of that already, and what we're bringing today is the updated version of the Health and Wellbeing Strategy, and then a relatively new document that's come out of the creation of the Integrated Care Boards and the Integrated Care Partnership, which Pete will talk about. I'll just pull out the real key points from the Health and Wellbeing Strategy. We have now 5 priorities as agreed by the Health and Wellbeing Board for the strategy, and they're actually quite different to a lot of other health and wellbeing boards and strategies across the country. Carers, and we've talked a little bit about that already. Healthy weight, which actually covers a lot of diet, nutrition and physical activity. If we could turn physical activity into a drug, it would be, you know, the drug that everybody should take. Homes for Independent, which really is that much broader debate around housing, and we'll pick up some of the wider issues there as well. Mental health and dementia and physical activity. And so, as I said, our priorities, I think, reflect very much what we've talked about already. How that interfaces with the integrated care strategy, the health and wellbeing strategy are the what do we need to address, and the integrated care partnership strategy is the how are we going to do it, which I'll pass over to Pete to talk about. And the 3 documents together describe how, whilst they are separate, and because of central government and Department of Health and Social Care and NHS England, they have to be separate, much to Councillor Woolley's disgust, as I'm sure she would say if she was here. We have done everything we can, because in Lincolnshire we've got one integrated care board, one upper tier authority, really good relationships with our districts, to bring them together as much as possible, and that's why it's packaged up in the way it is. I won't say anything on the health and wellbeing strategy because I'm sure scrutiny members are cited on that. That's something that we've had for a while, and I'll pass over to Pete to talk about the integrated care strategy.
Yeah, thanks, Derek. So it's exactly as Derek's just said, there is a legal requirement to have an integrated care strategy, and largely I think there's only 3 integrated care systems that have coterminous health and wellbeing boards and integrated care partnership boards. And that's why in our area, or one of them, you think, why have you got these two documents? They don't work together. And we have worked strongly in terms of our the web presence, in terms of trying to pull the information together so they look more seamless than just being two separate documents together, and making sure there's commonality across them both. We brought the interim strategy here last year, and it had the 5 kind of priority enablers in that. We've looked at that and refreshed what they were. So just to be clear, the first one hasn't changed. That's around the life cycle prevention, around prevention, and looking at the life cycle process, and that goes back to working with people from young age, preconception, adolescence, into working age, and the rest in terms of how we kind of help shape that. The workforce element has been changed slightly. So last time it was more broader around the whole workforce. Actually, this time it's more focused on keeping people locally to study and get roles within the health and care sector, and also then focus on how we have people in our health and care sector, how we upskill them, how we look at the skills gaps they have, and how we can help them progress their careers through the health and care sector. And that's a kind of a joint approach across all organisations. The final one, the personalisation, so that hasn't changed. There was a new part of that, a new theme in there around community engagement, but the personalisation is part of the key from the previous conversation around people taking drugs, as in prescribed drugs, and what matters to them. A key part is what matters to those individuals, what is important to them. Not a patient, they're a person, and actually it's a cultural change process within personalisation. Also key in there that you will find, which I'm not here to talk about today, but the joint forward plan of the NHS, is that new relationship with the public. We need to have a far stronger relationship with the public, and that's something we need to progress over the future years. Get into the groups, the seldom heard groups, people in our communities that we have not got engaged with. We need to work with them on that and find out the healthcare they need and what matters to them, because there are parts of our population who want the digital health, and there are clearly parts of our population that doesn't work for. So how do you work that through? That leads into the digital health. So one of the ones that we took out was around community engagement. That was a previous priority enabler. That's because there is a community engagement strategy that the county council lead on, but there is an element in the personalisation where that work with communities and how communities can work, say on loneliness or supporting people with their health in terms of being active, plays in that element. So, but the fourth one that's coming is around digital and how we support people through digitalisation to maintain their own health through advice, feedback, and support they can get through digital platforms, and how we can utilise digital kind of platforms and devices to help care for people locally at home so they can continue with their lives rather than be inpatients in hospitals. And then the final one those two enablers kind of got stripped out together because we did have data and digital in the last interim strategy, but it's more focus on the data. So how do we have joined up data so people aren't just constantly speaking to different people about the same issue, and actually how do you bring in someone's housing concern back into, so there's a shared care because people understand, okay, it's not just about your condition here, but I see you've got these other activities that are taking place, and how can we kind of have a holistic approach to care? And also, how do we plan for care in a more effective way? We're going to plan differently, as Dirk said in the previous item, and have a different healthcare system. We need to look at all the data we have and work in a more holistic way. And well, how do we plan healthcare based on all the information we have, rather than having subsets of information between organisations? So they're the key kind of enablers that we're taking forward, and welcome people's views on them.
Okay, I've got Councillor Wood first, please.
Thank you for your report. So on page 70 of the agenda pack, it talks about Lincolnshire having the highest amount of care homes in England due to our ageing population. I appreciate that it also mentions about trying to recruit more carers, but I think it's a bit more of a wider issue. So my mum's a carer, but she doesn't have the ability to concentrate all of her time on that, because she also has to do all the housekeeping, and she's a kitchen assistant there as well. There's a lot of jobs that they have to undertake, and I think there's a lot of pressure on how care homes are actually operating. So even if there were more staff, would they then be able to focus on their actual job? So I think there's just a lot of issues, and I'm quite concerned about it.
I completely take the point. I think the issues around care homes and staffing is one that's discussed quite a lot in adult care community wellbeing scrutiny, and is something that Martin, now as the Director of Adult Social Services, would, I'm sure, be happy to talk through in detail. It's not my direct area, but clearly, as the DPA's report demonstrates, and as we move forwards, we need to recognise we've got an ageing population and make sure that we've got the right sort of services in place. I'm sure Martin would be happy to go into a lot more detail on that, including the workforce development bit and making sure we've got the right workforce coming through.
Is it okay to just ask? But yeah, thank you for your response. Obviously, a lot of care homes are private. Are there proper guidelines put in by the NHS, or can we control anything into how the care homes operate?
Shall I start with that? It depends on what aspect we're talking about. We have a really strong relationship with Lincolnshire, who are sort of the umbrella organisation for care for a lot of care homes, not all of them, a lot of care homes across Lincolnshire. If I talk about my world, so health protection, outbreaks of infectious diseases in care homes, etc., we have a named individual in every care home across Lincolnshire who is our key link person, so that if there is an outbreak of diarrhoea and vomiting, or COVID or flu, they can come straight through to us as a county council public health team. I don't think there's another council in the country that does this, and we will support with dedicated health protection nurses about what they should do and how they should support and minimise the risk. So we've got really good relationships, but of course they can always get better. There is guidance, and there will always be guidance for care homes around how to look after their clients and patients in terms of NHS guidance, and of course not every care home, in fact only a small number of care homes, will have nursing staff on site as well, and nursing staff are registered and have a whole different system. I don't know whether, Pete, you want to add to that?
Yeah, I don't think there's much more to add. Obviously, care homes, not all, but CQC registered as well, so they have inspections in the care they provide. And we, again, through general practice and primary care network, they have linked GP leads that can work with them as we go forward. But as you say, we are trying to put that relationship. Lincolnshire, when Lincolnshire, in terms of part of the ICP strategy, a formal part of our Better Lives Lincolnshire Alliance, in terms of being core to kind of delivery of this and being core in terms of its development. And actually, that isn't the case in every other system, neither the third sector, but they are in Lincolnshire. And I think those relationships will only help improve the issues that you can sometimes face.
Okay, thank you. Councillor Allen.
Thank you. I could almost ask the same question again that I asked first time round, but I'm not going to do that. I was interested in your comments about that this can't, these strategies are going to be very difficult to deliver within the capabilities of the current healthcare model that we've actually got, and it's the healthcare model that needs to change to actually provide the basis then for these strategies to actually be introduced. Which are vital in my view, because prevention of health issues and dealing with the subsidiary aspects that interact with health are vitally important. But if we haven't got the core function working properly, there's always going to be difficulties then in terms of those having the effects they ought to have. You said it. The healthcare model that we've got did work, up to the 2000s or whatever it is. It's from then where the pressure started to come to bear, which caused some difficulties. And you also said, it's a question for the country as a whole in terms of working out what it is that we go for. I might suggest that it's maybe not simply money that comes into it, it's a bigger issue. I mean, we're spending something like 52% of all government spending goes on health and social care, which is substantially bigger than it was when the health welfare system started off many years ago, and indeed is more than all of the other government expenditure put together. So it's maybe a question of working out how the funding is spent and what extra funding is to actually provide real benefits than anything else. But how do we get to that stage It's been evident, you know, as you say, for 15 years or something like that, 20 years maybe, that it's not working particularly well. Money has been thrown at the problem to a certain extent, although the outputs don't seem to change significantly, if improve at all. So what is it that has to happen to actually bring about the start of this significant change, never mind bringing the actual change into effect? Because nobody seems to want to, I think it's well recognised what the issues are, but nobody seems to want to do anything about it.
Might look at me for that, Pete, thanks. Yeah, there isn't a magic wand. I don't think anybody thinks there is a magic wand. What we've got in these documents is, I think, quite a systematic way to start to chip away at the problems. So the idea that we can just throw more money at the NHS and that will solve the problem, I think, is wrong, and we would accept that. And if you look at the priorities in the health and wellbeing strategy, none of them are NHS priorities. They are all about carers. They are about mental health, not mental illness. They are about physical activity and how that will cut across. And they are about things like the built environment, like housing. I think transport is another cross-cutter. We've not pulled it out specifically, but certainly in Lincolnshire it is a cross-cutter. And then you look at the how. How are we going to do it? Well, we've got digital and technology because we can't ignore it. Certainly we've heard examples that I completely accept. We need to have face-to-face consultations with individuals where that is the right thing to do to get the best clinical outcomes. But there's a whole range of other things that we can do to create the capacity within the system. And that's really important. And that's one of our priorities. We need to understand the population need better, which is where bringing together our data and our intelligence into one system is what we've already done. That's been hard work. You can't underestimate how much time and effort that's taken to connect up intelligence that a general practitioner has on their system with the hospital data. You would think that was connected already. It wasn't. It is now. We do have that now. We also have 111 data. We have 999 data. We have social care data. We haven't really got housing stock data. That's something we want to put in. We haven't got prescribing data. That's something we want to put in. But we've gone from lots of separate bits that didn't connect up to a big chunk of data that is connected up at a patient level. And we need to keep adding to it. So it is turning the proverbial oil tanker. It's going to take time. It's going to take the combined efforts of society to do it. But what we're trying to do through the strategy and the papers is demonstrate, one, we've got a plan. Two, we're already delivering on that plan. And three, we need everybody to support that plan. I think the final thing I'd say, and I would say this as the Director of Public Health, is I've estimated, let's say we spend £2,000 million in Lincolnshire on health and care. The public health grant is 36 million, of which we spend about 11 million in children's services, focusing on holiday activity clubs and toothbrushing and all the things that we need to do, physical activity in children and young people. We spend a chunk of that money on frontline NHS services like sexual health, substance misuse. So actually, maybe 10 million that we've got left is about trying to prevent sickness, and 2,000 million is about trying to deal with the illness that we've got. We're going to have to figure out a way to change that amount of money, and we are working on that.
With your indulgence, Chairman, I think that last point is the key to it to a great extent. You know, we ought to be spending an awful lot more on prevention than cure. You know, but it's going to be difficult to get to that stage and to provide a model that allows that to actually happen, because it's the health service that we've got, and indeed the dental care one that we've got in the NHS dental care one, is very reactive. You know, they're very good at taking things out, but you know, it's not very good at preventing things having to be taken out, shall we say. And I don't want to denigrate what you're trying to do with the money that you have access to and the money that we're responsible for, because it is very, very important. But I am fundamentally concerned that the fundamentals will always be there and will always, to a certain extent, frustrate delivery, and it won't be as good as it could be if the fundamentals were resolved.
Okay, thank you. Councillor Morgan, please.
Thank you. So a couple of areas. First of all, just around the housing, Homes for Independence title. I'm actually a bit concerned about that because we've just been discussing previously the risks around isolation for elderly people. And I've been a home carer, and I was quite shocked at the how isolated, if I want to phrase that, people are, especially coming out of hospital. They've got medical conditions, they can't go out, they rely on carers only, and sometimes as a carer you were the only person they ever saw. And you might have a 20-minute session with someone to go through about 10, 20 tasks. Sometimes, I'm not exaggerating, I wish I was, in that 20-minute session with that person. And it really worries me. I don't like that term, Homes for Independence. I'd far rather that the phrase was more like appropriate housing or appropriate homes, so that we've got a much more tailored solution around care to meet the needs of the individual, and we're looking at them more holistically than we do at the moment in reality. So I just want to make that point. I'd like to pick up on the healthy weight as well, because I like that title, because it's very encompassing. But we immediately talk about obesity. And we know with the cost of living crisis that we've actually got another issue, and I know UNHT have had to spend an awful lot of money on this, and that's malnutrition, underweight. And that's an increasing concern. People with dementia, I know it's very difficult, but also we've got young children coming up who are not getting the nutrition they need. And if you actually look at the increase in figures, it's absolutely shocking. We had 90 cases in 2022. We had 145 cases in 1 year. The increase, if you look at that as a percentage increase, that should ring alarm bells across the board. So I'd like to see within here a strategy relating to that, as well as dealing with people who are overweight, regardless of their age.
I think the short answer to that is, in terms of the titles, obviously it's a discussion through the Health and Wellbeing Board and with the leads, but in terms of the healthy weight bit, all of the priorities have delivery plans that underpin them. We happily share those as they're developed with Scrutiny, and that goes into the level of detail, Councillor Morgan, that I think you're talking about. In terms of the healthy weight programme, it does absolutely tackle underweight and malnutrition, as well as overweight and obesity and morbid obesity. The reason we call it healthy weight is it's just that. We want to help people get to a healthy weight and maintain that, whether that's up or down. It's maintaining a healthy weight because we know the benefits. But we've got a delivery plan, and Andy Fox, who leads that, along with Councillor Woolley as the elected member lead, I'm sure would be happy to share that.
Sorry,
Can you put your microphone on, please, Councillor?
Just pick that point up as well, regarding the housing and the homes, and the fact this independence is an expectation. People will be independent, but that can mean isolation. So it's how we balance.
We'll make sure we feed that back. That's actually chaired by Councillor Bokit. So maybe a conversation there with Councillor Bokit as well would be useful between councillors.
Thank you. I've got Councillor Makinson Saunders next. If I can just ask you to bring your microphone round so that you can actually speak into it, so we can all hear, please. Thank you.
Sorry, I've got a cold anyway, so it's difficult. Page 71, it tells us that there are nearly 25,000 static caravans. I actually chaired the caravan scrutiny at East Lindsey, and I could bore you to death with how many caravans we've got. They are more like, it's closer to 40,000. And something we did learn in the scrutiny, that people are living in very substandard conditions in these caravans. A lot of people choose to use their caravans because when they're going through palliative care, they want to die at the seaside for some obscure reason. And palliative care staff are really struggling to be able to deal with people properly in such confined spaces. And that is a huge challenge. And how we give people what they actually want at the end of life. And it was something that really was highlighted. A lot of these people don't because 40,000 people, 40,000 caravans, and they've all got quite a lot in them, but a lot of them do not register with doctors. So they are presenting later when disease is, it's less easy to treat then. So I think the caravan sites are a big problem, and that's why Chris Whitty and you are identifying such awful problems with that. It is going to be difficult to do. Eastland, and I'm going to be nasty to Eastland here, they have avoided sorting caravans out for 30 years. It's time we did sort that out, because it does backfire on the national health. It does backfire on so many of our services. So we need to get to grips with that. So if you could correct the number of caravans there are, and bear in mind that the problems that those are bringing to, it is the most in Western Europe, you're right, but that needs picking up really promptly.
Thank you. I think that's been picked up. Councillor Martin.
Thank you, Chairman. I noticed data and intelligence is mentioned quite a lot in this report, and obviously strategic enabler number 5. From my current experience of data intelligence gathering feedback from the customer, unless something drastically changes with that, you're going to really struggle to use the data properly in order to make savings and find out where your issues are along the line. In the last 6 months, I've had a vast amount of experience with hospital admissions for my elderly father and the way the system works for ambulances and such like, patient care on the wards, in and out of hospital, lots and lots of things going on. There is virtually no space in there for feedback. I could give you a list of the length of my arm of places where you could actually make savings and make efficiencies, where things have gone wrong, problems. And as I say, that's the focus I would like to see from this, is actually to say, look, it's not a one-way process. It's not for us to tell the customer what we're doing. It's the other way around. You need to be talking to the customer and saying, where are we going wrong? And get a full understanding of where the issues are, so you can actually come back on those and correct them. Because, as I say, there's a vast number of things. I mean, I'll give you a very quick example of one. My father was admitted into hospital, he was on a ward for 2 weeks. The second day he was in there, we received a phone call at home from an automated machine saying, how was your stay in hospital? That was 2 days into a 14-day stay. He obviously wasn't there. Never heard anything more about that. It just disappeared. There's so much scope here to get feedback and understand what the customer actually is experiencing and where we can correct things. And I'd just say it'd be worth highlighting, actually working on that specifically, rather than what we're going to tell people, actually listen to them back. Thank you.
I couldn't agree with you more in that sense. And if you look in the personalisation bit, is the kind of new relationship with the public, and the NHS Joint Forward Plan, that is the heart and soul of that document, because it's not about just listening, it's about actually co-producing care pathways, working with people with lived experience in terms of how they interact with the service, how it could be improved and better meet their needs. But you need to do that in a holistic way, because people have different needs in different communities and that kind of stuff. So that whole approach, it's not going to be easily done, because people go in and out of hospital and that kind of stuff, but we need to, as an NHS and as an ICS, proactively kind of take that on and make sure that that does happen. Mental health services are better at it in terms of co-producing, but in physical health services, it's something we need to get better on. But I think that's why it's in the ICP strategy as well, because we can learn from each partner who does as well, but also we need to collectively do it, because some of the issues come when you hand from one service to another. It might be an NHS service into a care. So how do you make that better? You both need to work on how does that affect the patient, their families, their carers, what matters to them, and all that kind of approach going into it. But it won't be easily solved. But that is why it's in here, because you can hold us to task for, well, how are you doing that? Can you demonstrate what you're looking to do there? Have you brought the voice of the population into, and the communities into, what you're trying to do in X, Y, Z kind of service development? So yes, I don't disagree.
Okay, thank you. I've got Councillor Parkin next, please.
Yeah, it's just really a follow-on comment from what Councillor Morgan was saying about healthy weight and that whole. There's some real conundrums and paradoxes within this. It is quite possible to have somebody who is both overweight, obese or morbidly obese and yet undernourished. And yet we tend to talk about the undernourishment as something to do with being underweight. It's also possible to have somebody who is on the larger size be more active than somebody who is healthy weight and slim. So I think we can distract ourselves sometimes a little bit and not really talking about the issues. But I know there's a lot of research, particularly in the States, looking at this conundrum and this contradiction, that in fact you can both be obese and malnourished. And I think that's a real indictment actually on our modern societies, that you can have that contrast. But it's true, and I think that shows the complexity and the paradoxes and the contradictions that are actually inherent in that area.
Yeah, as usual, I completely agree with you. I think one of the things to focus on, though, is that the majority, and within a public health setting, we don't deal with individuals, we're looking at population change. The majority benefit we can get is by focusing on maintaining a healthy weight. And clearly part of that is diet and nutrition, as well as a separate priorities around physical activity. So you're absolutely right. If you are overweight but you are physically active, as an individual, your risk is reduced compared to somebody who might be a healthy weight but is completely inactive. But at a population level, we want everybody to maintain a healthy weight and to be physically active, and recognise that the intersectionality of that is always going to be complex and complicated. That's the nature of the day job really for us. So completely agree with you, but if we can shift the majority of people 10% towards a healthy weight, whether that's underweight or overweight, as well as increasing physical activity, we will see a very big impact on the general health of the population, but also in terms of health service utilisation, which then starts to create a bit of space to do some of the other things we've talked about previously. That's why this is 5 things, because of course there could be 55,000 things, but we've distilled it down to 5.
Okay, thank you. I've got Councillor Cleaver, please.
Thank you, Chairman. I'm glad to see that in the report, top level report, there's a reference made to delivery mechanisms, and that's great. Could you just amplify a little bit? It says there'll be a system responsible officer and an enabler, delivery lead. Sorry, delivery lead. Could you explain why there's both and what the difference in roles between the two is? Because that didn't come across to me in the documentation. But also, could you just explain how their performance in doing the delivery will actually be monitored, and who they report to, and where do they sit in the structure of the system, please? Thank you.
So yes, so for each enabler, the aim is to have a senior responsible owner who's going to lead on taking that forward. So if you take in the ICP strategy, the prevention piece, Derek is that person, so he's leading on taking that bit forward, and that would be the ICP will obviously monitor the delivery of the kind of plan that sits underneath that, and then the same with the other 5 enablers. So some of the people in the NHS in terms of digital and data and that kind of piece, but they'll look at what the plan is. So actually, this senior responsible over for personalisation is the third sector. It's Chris Reray, St Barnabas, so it isn't even either. Isn't anyone from the local authority or the NHS. It is meant to be an integrated care strategy, but they will then, not just directly, but they'll have a board that works for them and develop the plans, then monitor the delivery of those plans, and they'll go back through the ICP as part of that.
And if I can add to that, I'm the senior responsible owner. I don't know why not officer, but for both prevention and health inequalities, and at the moment the digital and technology areas. And I guess I see that role as making sure that we have an action plan, we know what we're doing, and making sure that all of the partners are in the same space, because there's a huge amount of work going on, for example, around digital and technology. But there's a real risk that we're going to increase health inequalities, given the conversation we've had earlier, if we don't apply that digital and technology in the right way. And as the SRO, that's part of my role. And I'll be going to, and I've forgotten what the name is, later on today to report on
the subcommittee.
Yeah. So we've got basically all of the NHS chief execs and chairs come together, and I'll be reporting into that group about what we're doing. But I'll also be challenging that group to say, and actually Andrew, as the chief exec of the group now, the hospital, the acute hospital and the community trust, your officers are doing this and they need to do this. Can you help sort that out? And that I think is the role, and that's actually been agreed by all of the chief executives, that is the role. So we should, we've not had it yet, so we should have the authority to make some of those fundamental changes that we've talked about this morning.
Thank you for that information. So in terms of structure, then, each of the SROs will report in writing to the ICP 6 monthly, annually. How formal is the reporting mechanism and the sort of monitoring?
Yes, so the intention is they'll report into the Integrated Care Partnership on an annual basis. Yeah.
Okay, thank you. I've got Councillor Scalesi, please.
Thank you, Mr. Chairman. Thank you for your report, and thank you for sorting my Wi-Fi out. I work frontline on health and social care. Previous to that, I was SRN at Peterborough Hospital and King's Lynn. I work in a person-centred living, domiciliary care, and it's a fantastic service to work in. Mine are all good. It's all good. We have people that we support with LD there from 18 years to, we've got one gentleman, 101, and he's been with us now over 60 years. So what we do promote is choice, diversity and equality. We do good dietary needs for them. We do really good shopping for them where they have fresh meat, fresh vegetables, etc. And the exercise programs that we do, we sort out for them. And even the 101-year-old will sit in a chair and do chair aerobics, which I think is fantastic. I know, it's really good to see. You know, and I just want to say, and we've also got a lady, she's 58, with quite severe LD, and 5 years ago she wanted to go to work. So I took her around everywhere in Spalding to try and get somewhere. You know, it's awful really, because some of the employers will talk to the person, to me, and not the person, when they have got mental capacity. Anyway, we got to the last one, which was Costa in Spalding, and I said to her, right, we're going to stay here till we get a job. And we did, and she's been there 4 years now. She does 3 hours a week on a Tuesday. She gets the same pay as everyone else. So, you know, mine's all good points for health and social care. So we do a lot. And also I do go out in the community and visit the other side, so the more elderly and the more vulnerable probably in their own homes. And, you know, that's a different story, obviously, but, you know, we do some good stuff out there, and we work well with LCC as well. Thank you.
Okay, thank you. I've got Councillor Smith, please.
Thank you, Chairman. In terms of what's been discussed around weight, it actually goes back to previously what Councillor Megginson-Saunders says. Part of the issue is, certainly for my generation, is, as has been said, living standards have actually gone down, so it's actually become harder. We're expected to work twice as hard as, say, we were at other ages as well. So you get to a point and everything is just so difficult that actually you're keeping your head above the parapet just, and you're functioning. You're not living. You know, and it's the same with, you know, trying to get a mortgage. It's you become almost sort of detached from parts of society, and you think, well, it creates a vicious circle, and you think, well, what's the point? I'm functioning, and that'll do, because that's all I can do at the moment. Which again goes back to physical activity. If work is becoming less physical, as a rule, less physical in terms of what jobs there are, and you're predominantly sedentary, whereas a number of years ago there were a lot of physical jobs, whether it be you'd be farming or you'd be in heavy industry, and you were physically active during your day job. So actually you were exercising whilst working, whereas now a lot of work is, as we are here, Tim, we're in a meeting, and then by the time you've finished, you think, oh, well, it's 5 o'clock, I've not done anything, but I've got to go and cook, I've got to go and do the day, the normal domesticated things. People simply don't have the energy, or what they feel is the time. What I would like to ask in terms of mental health, and it may be different in mental health, but Derek, you sort of touched upon it in terms of weight, that you're doing a broad sort of approach to get the most sort of bang for your buck. Now, my concern is if we take that into mental health, we're going to have a problem, because mental health is exceedingly complex, and in terms of, say, veterans, for example, you have complex PTSD and why it's triggered. Even in PADS brats, they don't have PTSD, but they could have mental health or anxiety, because actually they don't feel like they actually really belong in any part of the world. They didn't serve, but they're not a civilian either. So actually, where do we sit in society? You get that loss of connection and that loss of purpose. So it's how are we addressing mental health, and especially those with disability, because they will potentially have trauma around their disability because they've wanted to do something in life, and their disability has prevented them from doing that. And that trauma can be bubbling below the surface and with them forever, potentially. That's a very real possibility. So it's how are we using this strategy, but also making sure within the strategy and the ways of working, we don't lose the person. The person doesn't become a number, so we actually accept the nuances and differences, both in terms of potentially comorbidities around weight and physical activity, of which, as Councillor Pong said, there are numerous examples of that. And also around mental health, because it's all well and good having these strategies, but if they then don't in them allow you to see a person and it be person-centred, then really you're going back to what you, in the previous report, Derek, said. We've got to have that conversation around a system that works for an individual, not just a health outcome. So you're not just a number in a system. So it's how is that going to function in reality?
I think a couple of things, then I'll pass over to Pete. Hopefully Scrutiny members have got the message that certainly from my perspective, and I know from Pete's perspective, and within the integrated care system, we are pushing the person-centred approach. That is the whole point of the personalisation, a key enabler, but it's a cross-cutter. In terms of mental well-being, mental health and mental well-being within the health and well-being strategy, the first aspect of that is about keeping people fit and well, both physically and mentally. Building resilient communities, supporting children and young people. There's a whole range of work that we do there. But clearly, when mental ill health presents, we need to make sure we've got the right services and support. And those two, they are and both, not an either or. And I'm sure Pete will talk about that. So nothing we're putting in here is saying, and we'll do that at the detriment of specialised services. What we've got to do, though, is create space to, if we do have a real need in specialised services, we've got to create space to meet that need. And at the moment, we haven't got that space, because despite that, £2,000 million, it's not enough. So that's about the prevention, whether it's the keeping people fit and healthy or managing them in the best way possible within their own settings.
Yeah, just to add to that, that's the personalisation bit. What matters to you conversation in terms of what's important to you in your life. And so people at different stages will have different needs, will have different requirements, family, kids, elderly parents. You need to that holistic care around, just rather than treating the condition, speaking with the person, saying, okay, what really matters is if you could go on a drug, but actually, well, could you go and do exercise? How's that going to work? But you can't just prescribe exercise, because I'm someone who does exercise regularly, but I do it because my kids are at an age where I can go and do it early in the day, and I can leave them. I can just go out early, but you can't do that when the kids are young. And that kind. So you have to have that. Where are you in your life, and what are your assets, and what are your opportunities? And that's what personally is a cultural change program, rather than just how you do that in a way that what really important to that individual, and that would then play into mental health, healthy weights, and all the host of different aspects really.
Thank you. With your indulgence, Chairman, and it's a very brief question which I forgot to ask, and it relates to my role in the VAPC, because we had this discussion only yesterday when I was at RF Cranwell. Things are, not just in the NHS, but in what the area I was discussing, they're looking increasingly to a voluntary sector, but especially, and I'll use the voluntary sector in terms of the forces, because that's my area of knowledge, more so than, say, other schemes potentially. That system is not where it was pre-COVID. There are a lot of charities, and I'm talking national charities, so I'm talking the likes of the RBL and SAFA, to use two examples. Things they were doing, they are no longer doing. So we're at a really interesting, it's also potentially quite dangerous, where we're asking the voluntary sector to do more. Well, actually, the voluntary sector is actually doing less, because it can't function and do what it was doing. So how do we have and I appreciate, as you've already said, the NHS cannot do everything. It's not sustainable for a whole host of myriadic reasons. So there is a cultural change that needs to happen. There is a societal change in terms of what we expect it to do, what we expect to do ourselves, how we expect it to function. But how are we creating that, if you like, that safety net, that actually we're not pushing everything onto either us here at the County Council or the District Council or the third sector, because actually both systems are, in different ways, really struggling, and especially in cash terms compared to health. We're not as fortunate in terms of cold hard cash than health. It's notwithstanding the comments we've already had today around it's not enough. What do we do? Does it become less? Does it become more? Where is that safety net if, for whatever reason, what we were hoping, say, the voluntary sector to do or for us to do here or at district council level, we find they can't do? But also, there's a question of, can you do it? And if you can't, where do we go?
Yeah, I agree with that, and I think we talked earlier and touched on it earlier. We have voluntary and community sector representatives at the senior meetings, at the Health and Wellbeing Board, at the Integrated Care Partnership Board. As Pete said, the personalisation key enabler is chaired by Chris Weway, from St Barnabas, so they are fundamentally wrapped up. But I absolutely agree with you, Councillor Smith. We've got to find a way, not just to say, well, the third sector can do it. We've got to find a way to support, fund, resource the third sector to do those things that the third sector will do better than a GP or another clinician or a social worker or whomever. And we've got to create the space to do that. So, yeah, absolutely agree with that.
Councillor Morgan, I will allow you to come in briefly.
It's just really quickly on the tail of that. One of the issues I'm coming across in supporting the third sector, it's really basic things. For example, insurance costs, access buildings, where they can actually set themselves up. You might find you've got willing volunteers, but it's the roof over their head. So if there's anything we could do, we can make a huge difference to those organisations, or number of them, if we can provide that really practical support. And a lot of the support you used to get through the local authorities has gone. Those pockets of funding have really diminished. The UK SPF fund, I know we're rolling out, for example, across the districts at the moment, but that's got a limited time frame. Once that's gone, that's gone. And we're very aware there's probably a much bigger queue for the support there than actually we're able to meet the needs of.
In terms of sort of the built environment stuff, I agree. We've done some work, and I think it might be on the Connect to Support website, but we can double check about mapping out the buildings that are in the public sector. Well, I think there's a couple of bits. There's what have we actually got where there might be capacity, and trying to connect up local community groups with those. Alison, do you?
I'm not sure.
No, I'm pretty sure we've done that, and we'll give a note afterwards if that's okay. because Connect to Support is not just about the community groups and third sector organisations and others that are in a place. It's also about the buildings that are in that place, and connecting the two up, it could be really powerful, and we have done some work on that. I'll check whether it's on there, and we'll share it afterwards. But the rest of the points, absolutely, yeah, understand.
Thank you. I have no further speakers, so I've just got 3 questions myself. My first question is, the report explains how these 2 strategies relate to each other, but how do they relate to other strategies? For example, the NHS Joint Forward Plan for 2023-28 or the Primary Care Access Plan?
So the Joint Forward Plan, definitely, if you look at the as they're published currently, you can see the commonality, you can see they use the same JSNA data, we work collectively on them. So when the NHS, when we did the Joint Forward Plan, we had ICS partners around the table in terms of development, and there is linkages between what that covers as their enablers to this. So the shared agreement piece in there is part of the personalisation of the ICP strategy, but there's an acknowledgement in the NHS that we need to do a lot more in that area. So there's definitely a complete linkage between the two. The primary care access strategy is a national strategy, but obviously that does play into our Joint Forward Plan in terms of access to healthcare and how that happens in that regard, and actually that wraparound support. But that is harder to do when you have national kind of strategies, and the aim of these strategies is to go, we need to act to that, we're mandated to do that, but how do we develop our services and our approach locally to better meet the needs of our local individuals and our local communities? And that's part of the purpose of these local kind of strategies.
Okay, thank you. My next question is, do you expect any immediate changes in approach or new services from the NHS, in particular LPFT, as a result of the mental health and dementia priority?
So, not immediate kind of in terms of, I can say there's going to be an immediate change in that, but it's more that focused approach and how we work with partners, and I think actually it's quite well established within the Mental Health and Disability Alliance. Is around the whole point of integrated care systems is around that joint partnership work across different organisations and agencies, and I think that's the bigger change, to have that wraparound holistic support. Because going back to the prevention piece, that was in the 5-year forward view that was published by Simon Stevens back in 2012, and then it was in the NHS long-term plan. And I think the reason you've moved into integrated care systems on a statutory basis because the NHS can't deliver that on its own, and that's where that's why we've moved in this direction. We need to work collectively on how we address those pieces. So I don't think there's immediate kind of care change. I think it's about how we wrap around our support and how we work together in those areas to make sure we kind of cover the needs of the population.
If I could just add to that, I think in the mental health space, it's really important to recognise that Lincolnshire's got one of the biggest Better Care Fund pots, which is the shared fund between the NHS and the council in the country, £300 odd million in that pot, and the MHALDA, I always get the acronym wrong, which is the mental health, learning disabilities, autism group that delivers is funded through that mechanism. So it's a shared approach really, which I think is quite unusual across the country. Just coming back to that thing about built physical environments, it is actually on Connect to Support. We've got some, it's under venues, buildings and facilities, and venues and places that run those venues can put the details on there and say, yes, we've got a room, you can come and use it if you need it. So I just ask all councillors to really make sure you understand Connect to Support, because it's not just the community groups. The more venues that you know have got spare rooms that you get, you ask them to put their facilities on Connect to Support, the more we can start to connect those up at a really local level, because people can put in their postcode and they can see what's around them.
That's very useful, thank you. My final question is, page 102, under the digital and technology enabler, how difficult is it going to be to overcome any scepticism of both the workforce and patients so that everyone can be confident in using digital services?
It's not going to be easy. You only have to look at the NHS history of digital systems and those kind of bits. But we are definitely a more digital society, aren't we? There's no doubt about it. And you have to look at how we've progressed in the past 20 years. So, but I think the key is about working with this is the key around that changing approach, working with the people who provide the care, working with people who access the care, their families, their carers, to make how does it work for you, rather than developing it in a sole kind of back office function and then saying roll this out and then this doesn't work and that kind of stuff. So.
And just to add to what Pete said, on a very individual level, we've got it wrong in the past, and what we've got to keep doing is improving. And if we think about the development of things like online banking, that has changed fundamentally. And I teach medical students quite a lot, and often talk with medical students about connecting up patient records and giving access, and the answer, oh, you can't do that. You can't do that because that would be the wrong thing to do, because what about patient confidentiality? And then I say, well, have you got an online bank? Yeah. And can you transfer money to? Yeah, can do all of that. And you're not worried about that? No. So you're not worried about your money, but you're focusing on patient confidentiality, when actually when somebody turns up in a gurney in A&E, having access to what the GP has prescribed to that person, how many times that individual has called 999 over the past 5 days. Would that be helpful to your clinical practice? Yes, it would actually. It's about starting to change our clinicians' minds as much as it is about the populations. And I genuinely think if you look at online banking and digital banking and how that's progressed, obviously there is digital exclusion there, I completely accept that. But for a chunk of society, how that's progressed, I think we will see that over the next 5 to 10 years. We saw it with the NHS app and the COVID app and COVID passports. You know, we will get there, but we've just got to keep working at it and recognise we're going to get it wrong, but the net direction is going to be, it's going to give better outcomes to people.
Thank you, that's useful. In which case, I'm going to move to the proposal. I think I'm going to propose that we support the strategy and the 5 priorities and the rationale for their inclusion on both the partnership strategy and the health and wellbeing strategy. Do I have a seconder for that proposal? Councillor Higgs. All those in favour, please show. Yeah, that's supported unanimously. Thank you. I'd like to thank our presenters. I think it's been extraordinarily useful, so thank you very much. We'll now move on to agenda item 7, Health Overview and Scrutiny Regulations and Guidance. This item was circulated as part of the agenda pack on pages 107 to 124, and I'm sure that Simon's delighted to present this to us.
Thank you, Chairman. This report sets out the new health scrutiny regulations that came, or amendments to the regulations that came about with effect from the 31st of January. It also sets out the new ministerial intervention powers, which I was initially intending to summarise in the report, but in the end I thought it was easier to attach the actual statutory guidance, which is statutory guidance for the NHS, not for local authorities, to the document. So basically, powers of referral to the Secretary of State have now gone, so that's done. That's not anything that's open to anybody anymore. Any referrals made before the 31st of January for any that were ongoing are still live under the old under transitional arrangements. We've got a new duty on NHS commissioners to actually notify the Secretary of State where they propose a reconfiguration of services which are basically going to be any sort of substantial reconfiguration. So they need to notify the Secretary of State, and there's a form in the well, not set out in the guidance, but I think there's a link in the guidance to a form that they are required to do so. So then, as it says, a notifiable reconfiguration is not defined, but it seems in the way that the guidance is worded that it is basically going to be a configuration which, under the health scrutiny regulations, we refer to as a substantial development of the health service or a substantial variation in the local health service provision. But neither those terms aren't defined either. So there is no definition of those. and I suppose in a way there hasn't been a definition of those elements, and that the way that the proposal in the report is that that myself and Pete Burnett are proposing to develop a draft protocol to bring to the next meeting, which would help with this, if you like, defining it or providing some guidance as to whether the committee would think that, whether the committee thinks that a particular proposal is notifiable or substantial or not. So that is something that will be covered in that. So we've got these new ministerial intervention powers, which are kind of, in a way, the replacement. One of the things is that they do enable a member of the public to approach the Secretary of State and request that the Secretary of State calls in. Now, there's also a form for members of the public to do that, and there are quite a few things that they will have to fill in on that form, and one of them is that they need to show that there has been every effort locally, including the involvement of this committee and the local NHS, in resolving the matter. So I'm probably speaking too long, but at the top of 109, I've listed what I feel are some of the roles that the committee may be picking up. Now, I don't know whether that's going to be a vast volume of business. I think, as I say, A is something that the committee has already done in the past, but it may be doing more often in terms of reaching a view on whether a reconfiguration is substantial stroke notifiable. And that's one of the things. I mean, the committee has done that twice in the last couple of years, but it may be more often. Some of the other things, I honestly don't know to what extent the committee is going to be involved in some of the other issues which relate to where a sort of an intervention has been requested or initiated. I think I'll just stop there and leave it for the committee, and I'm quite willing to take any questions. Thank you, Chairman.
Thank you, Simon, and thank you for trying to work through it. I mean, it's about as clear as mud, really, with what the new, legislation is there. In essence, it almost feels like we can no longer refer, but we've now become the gatekeepers for anyone else to refer, which just seems overly complicated. So I think it's going to create a considerable amount more work potentially going forward. But there's not a lot we can do about that, realistically. That's the legislation. And so, I thank Simon for the work that he's done on trying to help us through this, and the fact that obviously the work's going to take place with Pete to try and come up with something that will maybe make it simpler moving forward. So I don't know if anyone else has any other comments. Councillor Smith first, please.
Thank you, Chairman. Much as you, as you've said, it's clear as mud, and I find it personally deeply frustrating that we've had the power to refer taken away. I don't think that was the right thing to do at all, personally. And again, thank you to Simon for what he's done for trying to explain what is quite frankly, I'll use a more polite term in this circumstance, a mess. There is another term that comes to mind, which I won't use in a public forum. What I was going to say, Chairman, is, and I would defer to yourself and Simon on this, as you know, we both sat through the joint committee with regards to the reorganisation of Scunthorpe and Princess Diana Wales as well. I would be curious to know if this is something we could refer under the new regulations, because personally I think we have made every effort to try and resolve those problems locally, and frankly we're told to, let's be blunt, Chairman, we were told to go away, there's no problem at all, when you and I both know there absolutely was, because that consultation was a farce. So if it was something we could do, I'd be grateful if that's something we could look into. Because I think we would be, although we are not the immediate committee, I think the new regulations actually allow us a bit more brevity and a bit more wiggle room, because we don't, my own interpretation, and it is only interpretation, and I'm no expert, they allow us a bit more brevity and room, because what that basically says is, if we believe there is a problem, as we are not the referrer, we are only asking for it to be referred, we would have a bit more room. And I don't know if that's correct, but I would certainly welcome the committee's attempts to look into this to see if it is something we could do.
Thank you, Councillor Smith. I'll bring Simon in momentarily, but I think from what I gather, because Simon and I have discussed this in terms of, obviously the decision's not been made yet, still officially, when it comes down to the Humber acute side of things, so we were too late under the old legislation. That being said, now, as an individual, potentially, I think you could try and ask for it to be referred, and then it would go probably back to the Humber acute, board, not us. So that's the reality, because they are the board that oversees that. But I think Simon probably will have had conversations with his counterpart a bit more in depth than I have over, and Dean Gillian will probably have explained, I suppose, where they sit on it from the overview committee.
Yes, thank you, Chairman. The if you like, the relevant committee in terms of resolving matters locally would be the joint committee in the case of the Humber. So I suppose any statement that this committee prepared, we would have to provide evidence of where that committee, how that committee has tried to resolve the issue. And I'm not sure, unless they were to meet again and consider this, that we wouldn't be able to fill in that box on the form, because they would be the relevant committee for this one. Thank you, Chairman.
Thank you, Chairman. Oh my, yeah. Is that something we could ask the joint committee if they're willing to do? Because as I said at the time, Chairman, when this came back, I think we really missed an opportunity, and if we aren't going to refer that under the new legislation or even the previous, we're never going to refer anything. Let's be honest. I can't see a better instance to refer something than what we sat through over those two meetings, Chairman, because it was a total failure. Let's not pull any punches.
Yeah, I don't disagree with you, Councillor Smith, and I think across the conversations that's happened over the sort of, the committee there, I think if the opportunity to refer in the way that we used to be able to refer was a possibility, it more than likely may well have took place. I think we're just in a really awkward position moving it on, and I know, like I say, I think an opportunity was missed, but I think in terms of that committee trying to make the referral through the new process, I just can't see how it would be possible for it to work. But Simon, you're much more learned than I am.
Well, maybe what I perhaps can do is make some discreet inquiries how people are feeling in the other areas, if that's okay, and take it sort of outside the for an initial step. Thank you.
Yeah, thanks. So I think it's fair to say that even this committee would have tried to refer it as well. So, but yeah, when we are, unfortunately, where we are with this one, which is incredibly frustrating, and the timing was, quite good for Humber, wasn't it, realistically? Councillor Morgan, please.
Thank you. First of all,
Sorry, Councillor Morgan, can you move your microphone? That's it, thank you.
Sorry, this might seem like a really stupid question, but do we still have, at the moment, we're consultee regarding changes to proposals from the NHS providers. Does that still remain? Is this just focusing on the substantial changes, etc.? So is that, if I've picked this up correctly, though, I always have kind of a golden rule when I look at changes like this and democratic process and everything. Do we as members have the same right as members of the public? And it seems, what strikes me as being really, I say this wearing, as you know, a hospital campaigner hat for a moment, that the irony is I might be better off, or we may be better off, acting as individuals under this new process as members of the public, if we have got a concern and want to call something in, than being as a member of the committee where we are not able to, which to me is ludicrous. It's absolutely ludicrous.
So just apologies if the report wasn't clear. All the other elements of the regulations about the committee being the statutory consultee remain. So there will be an obligation for the NHS where it is a substantial development in health service provision to bring an item. And under these arrangements, we would be expecting a sort of an alert to that before the consultation begins, because the committee will probably be asked whether, in its view, it's a substantial variation, stroke notifiable variation, or not. So that's the easy one. The second part is that the committee could still make a request to the Secretary of State to call in, so it doesn't rule it out. But just as a member of the public would have to demonstrate what resolution actions have been taken locally, the committee would also, in its state, in its completion of the request, have to document its own efforts to resolve the matter locally and how those efforts have been tried and failed. So it doesn't necessarily rule it out. I think in each case, whether it's a member of the public or the committee, I think that it's going to be important to complete the form as fully as possible and put as much information in as possible. And I think one of the things in terms of members of the public, it could be that the Secretary of State will get a number of submissions made where there isn't really a sufficient completion of the form. But I may be wrong. It may be that members of the public may approach this committee first to say we are unhappy about that. So I say a lot of it is unknown at the moment in terms of how it's all going to work out. Thank you, Chairman.
Yeah, and I think one of the points that you made on the form that you fill out to obviously try and bring it to the Secretary of State is, where does it fit in if it says, do you feel what work's been done locally, and someone puts nothing or none, or that's their opinion that nothing's been done, well, how does that then land? Does it then bounce to us as a committee to say, well, we've done this, that and the other, for them to say, well, no, we're not happy with that, so it's nothing? But there's just so much to work through at the moment in time, and I think at some point it probably will come up against some form of legal challenge in what actually, is this, and what, is the interpretation of the rules, because you could say legally people will look at their own interpretation, won't they, for the right price sometimes. But, that's just, we're going to have to suck it and see somewhat. And I think that's why it's useful to try and work with our NHS partners, because I think they're as equally unhappy with the changes in regulations as what we are, I would dare say. So, I think from their point of view, they would like to see a simpler system. And I think they felt that the system that was in place, although not perfect, certainly works better than what is now in front of us. And that's the great difficulty we're going to have moving forward. Councillor Mackinson-Saunders.
Thank you. Well, for once, we do actually have somebody we could go to, because Victoria Atkins is our MP, and I don't know why we're not making more use of her to express our views. And our views are important, and I know we shouldn't be an exception, but why aren't we using, in the nicest possible way, her to tell her how dissatisfied we are and to illustrate how stupid the new scheme is? We'll never get a better opportunity, will we? And political pressure coming up to a general election, we know works.
I mean, the reality is, of course, when these went through, she wasn't the Health Secretary at the time, and so what actual input she's had on this, I don't know, but you're absolutely right, and it might be something that is worthwhile raising. I think all the way through this, going through, I think the LGA, did they not have complaints about this? So it has been fought all the way along, but it has landed on deaf ears. But I think, there is the potential that we do look at writing to the Health Secretary and raising our concerns, and those, I mean, it might even be something we can speak to our ICB colleagues, because I know they're unhappy as well, and list where we think that this falls flat. So, but if that was something the committee
we should try it.
Well, yeah, I mean, if that's a proposal, Councillor Mackinson. Yeah.
Yeah, I'm happy to propose it.
Okay, all those in favour on that particular one? Thank you, that's carried unanimously. So we shall see what response we get. So, but moving forward for now, I think we've got to take on board for the time being where we are. So I will propose that we note the following that came into effect on the 31st of January 2024. The Local Authority, Public Health, Health and Wellbeing Boards and Health Scrutiny Amendment and Saving Provisions Health Regulations 2024. The Local Authority Scrutiny Guidance from the Secretary of State for Health and Social Care. the Schedule 10A of the National Health Service Act 2006 in part, and reconfiguration of NHS services, ministerial intervention powers, statutory guidance from the Secretary of State for Health and Social Care. And then finally to agree in principle to a revised protocol being developed between the Health Scrutiny Committee for Lincolnshire and NHS Lincolnshire's Integrated Care Board, with a view to an initial draft being submitted to the committee's next meeting on the 20th of March 2024. So that's my proposal. Seconded Councillor Allen. All those in favour, please show. Supported once again unanimously, thank you. In which case I'll now move on to agenda item 8, the work programme, Simon.
Thank you, Chairman. If I could ask members of the committee to look at pages 126 of the pack onwards. We've got quite a full agenda for next time. We've already mentioned the Humber acute review in the previous item. We are expecting a decision on that on the, I think it's 13th of March. So that may be a little bit tight in terms of feeding into the agenda on the 20th, but we can see how that might work. We were talking in the strategy items and also in the Director of Public Health report items about voluntary sector. We have got an item that's going to be presented by Chris Weway, who is the chair of the Lincolnshire Voluntary Engagement Team. So this is maybe the first, it may be the first part of looking at voluntary sector support, which is going to be voluntary sector support for the NHS, which is potentially a major topic and may cover several meetings. But perhaps that's a starter on that one. There's one to add in, which is we've now got the planning one is, I think, the section 106 one is now the 17th of July. Oh, and I'm going to try and look at getting an update from LPFT, maybe perhaps slot that in for April in terms of where they are with some of these issues. And there's something else I need to mention. Oh yes, some members of the committee may have received an email about a meeting that's taking place in Louth tomorrow. Sorry, I've lost my note of this. It's taking, I think, at the Priory Hotel in Louth at 7 o'clock tomorrow evening. So some members of the committee may be aware of this. It's just organised by members of the public, but I would mention it because I know I'm aware that some members have received emails and others not, or are aware of it. So I just mentioned that in passing. Thank you, Chairman.
Did you mention a time, Simon? I can't remember if you did. 7 p.m. start, isn't it? Yeah. So I can't be in attendance, unfortunately, because I've got other meetings in East Lindsey, but anyone who would like to go across, I think it's open to the public as far as I'm aware. Councillor Morgan.
I was just going to say I have expressed a plan to go to that meeting. What I said was I'll just take any feedback and bring it back, share it with your draft report on behalf of us, really, and share that so we can look at what people have to say. My understanding is that it's very much, it's not campaigners, it's patient-led, basically, and they'll be putting in what their issues are, experiences that they've had. That's what I've been told.
Okay, thank you, Councillor Morgan. I think Councillor Makinson-Saunders has just said it is very much so campaigners. And
I think you'll find it is. The man who's organised it was the man that organised the campaign for one of the people at Save Louth Hospital. So, if you think it's just about people going into experiences, I think you've got the wrong idea.
I am actually a campaigner myself. I know Frank and I also know Bernice Cullenwell, he'll be there. But I've been put it like this, I'll play it by ear when we get there. I'll just pick up any points that I can. If anybody else is going, it would be quite useful to know. They were keen to have a representative from our committee there. I know that.
They never formally asked, I'm afraid. They sent an email without they sent a date, they didn't send a location, they didn't send a time. So It's been picked up on social media. That's how we've got the date. That's how we've got the time. But all that was sent was, would someone from Health Scrutiny potentially like to come? And that was it. It was literally 3 lines. So, and as I say, we found out the information from social media, and I've shared it out here at this point. So if anyone can make it, they can. As I say, it's just to make members aware, but it's nothing official from a health point of view. So, thank you.
Mr. Chairman, it's in a hotel. It's in a very small room. If you were going to have a public meeting about healthcare in Louth, of which there is a certain issue, you certainly wouldn't have it at the Priory Hotel. You'd have it in a large room where a lot of people could get into. So I'm not convinced. Well, I shouldn't really say that. I mean, I'd always stick up for healthcare in Louth, and I'd go the extra mile for them, but I'm not sure that it's been done in quite the right place.
Yeah, thank you for those comments. As I say, it's only to make members aware because it did come through. I've got Councillor Cleaver first, Councillor Morgan.
Thank you. I notice on the 17th of April we're down to discuss urgent and emergency care again, which is great. I think it's been a year. Obviously, it's 2 things just slightly concern me about that. One is, will that actually go ahead, given how reticent the NHS were to come and talk to us during PERDA last year when there were elections on? So can we check that? Can I just check that out, given our experience from last time? We've got PCC election going on. Yeah.
I don't think normally, I can't say with certainty, Councillor Cleaver, but I do believe that's not normally affected. I think the only time we tend to get pushback on PERDA is if you've got county elections or you've got combined like district and town or parish council elections where it actually will have an effect. I know that Councillor Hill will say very, very clearly the meeting goes ahead as normal.
No, I hope so, thank you. And
So,
sorry,
but it's useful. And in fairness, yeah, having it back, I think it's the review because, of course, when we did have our last urgent and emergency care, they did start a review. I believe that the review's finished by this point in terms of will they be keeping our UTCs open in Skegness and Louth specifically overnight. So I think it's incredibly important we do have that.
And can we make sure we get an update on Stamford MIU, please? Thank you.
Yeah, I think that's outside scope is what they've said, but we will pick it up. So thank you. And obviously March's work programme is, the agenda is looking pretty huge, to be fair. So I don't know if we might potentially look at moving stuff around or not, because it does look like we could be looking at a full day elsewise. I'll bring you in a moment, Councillor Morgan.
I think, well, there are 3 substantial items where we've got NHS people coming in March. I think the protocol item and the quality accounts item are a little more procedural. I think the Humber one is, I guess it's marginal whether it makes it on the agenda, because it may not be, that may be have to sort of go back to April. But if the decision is made on the 13th of March, I think it would be helpful if the committee could reach a view on that as soon as possible. But yeah, I think it's manageable within a sort of a 3-hour session. I don't know. I would suggest that. Thank you.
Yeah, I think we're building a little bit of leeway that we might potentially need to go past 1 o'clock though. Yeah, I think that'll be fine. Yeah, okay, Councillor Morgan, I've got you again.
Thank you. I have raised this with Healthwatch, but it's been brought to my attention that there are concerns regarding the availability of 24-hour pharmacies. I know in Grantham in particular there's a concern that we appear to have lost them, but I was thinking it might be worth looking at that as an overall issue across our county. We've got people obviously leaving hospital and unable to get the medication that they've been prescribed.
I'll bring Simon in. To be fair, normally pharmacies are, I know, quite well regulated, and when we've done the pharmaceutical needs assessments before, there's literally no wriggle room in it or movement we can put pressure upon. So, but I will go back to Simon on it, and to be fair with you, I've got to be honest, from the Skegness point of view, we've never had 24/7 access to pharmaceutical at all.
It might be a good idea to pick that up, because I think there are, in your announcements, Chairman, there was reference to the pharmacy the Pharmacy First scheme that started earlier this month. And then, so there's also another one on the to-do list, which is about using prescription medicine. So it may be an idea to have a sort of an overview. And pharmacy services were very much flagged up in the GP access plan, which the committee looked at back in December. There was a whole section on pharmacy, so it might be something to bring in all these topics in together.
Yeah, I think we can tie them all in together.
Yeah.
As I say, I do know when it comes to opening times and locations and everything else, it is so regimental, it's ridiculous. But more than happy to take that on board and add that, because I think we've already said about the lack of being able to get certain prescriptions and so on, so it'll be very useful. So anything further on the work programme, please? Councillor Wilkinson.
Well, just on pharmacies, and they're advising us to go and get advice. I went to a pharmacy for advice, and he said, oh my God, I really don't know. Go home and phone 111. I phoned 111, and they gave me pharmacy advice, which I then took to the doctor's surgery, and the practice nurse said, oh my God, she said, oh no, I don't think we could afford that. Here's 100 paracetamols.
Quite, yeah. I think while it's being rolled out, it's still a little bit on the complicated side. And I think some pharmacies, depends where you go, some are slightly better than others in terms of wanting to offer advice, and I think some are under considerably more pressure than others. So I think it is incredibly difficult. But yeah, it will be covered in all of that sort of side of things as we get more information moving forward as well. So anything further on the work programme? No, taking on board all those comments and the items that have come out of today. Are members happy to move forward with it? Yeah, thank you. Okay, that's supported. That brings the meeting to an end, in which case, thank you all very much for your attendance.